Yeah, start sharing.
Yes, yes, you're right. You're right.
You have to mute, sir.
Everybody get off your Zoom links here. It's working. The link that they sent me in the morning is working.
The slideshow is not coming.
Huh?
Slideshow isn't coming.
Why is it not coming here? What is this?
No, that is normal. Once you try slideshow again, is it coming here?
This starter. Setup slideshow. Yeah, nice.
ప్రెజెంటేషన్ ఒక తర్వాత ఒకటి మొదలు దగ్గర
Celebrations today. It's indeed, thank you, Dr. Ayala. Thank you, Dr. Ayala, for, pardon, sir?
First slide. Back one.
Okay, I'm not presenting this. This is our first slide. This is not my slide. I'm just doing a simple welcome address, that's all. I think it's indeed really nice. I think I just wanted to tell you how all this happened. I think way back when I started my practice in '99, when I started my practice as a retina surgeon, then I was predominantly doing retina work, and it was in 2010, I think me and Ayala met, and I always had a passion for teaching and training. Then Ayala also shares the same kind of views about ophthalmology. And so we said, okay, why don't we join together and try to build a teaching and training hospital. See, it's been 10 years now, 12 years now in this particular hospital, in this particular center, and we have already had around about 18 people who have passed out of our center, and there are a lot more to go right now, and which really feels really good for us. Like, you know, we have been, so our primary mission was to do teaching and training, okay. The second, for teaching and training, all of us, we need to realize that we need to do a charitable work. Some amount of charitable work has to be done. So fortunately, we had some good donors till today, and we are able to continue the charitable work. Whatever work we are able to do is thanks to all the small time donors who have been giving us, and probably in future, we are looking forward for having bigger donors. Probably it will happen in another year or two, where we will have more number of free cases for our fellows and our postgraduates who are with us. Now, I really want to admire and thank all the consultants who have been, like, you know, part of our journey, and I'm really fortunate to have such kind of consultants who are willing to teach and train, who are willing to actively participate in the teaching and training program and make the life of students much better. So a big round of applause for all the consultants. Thank you so much. I think me and Ayala, we echo the same thought, saying that I don't think it is possible for a single man to do everything, and it's always about the team. And for me, I think it's my team which speaks. It's not Satish Agraharam doing, or it's not Ayala doing, or it's not somebody else doing here. I think it's the entire team of Ananda Institute which deserves a big round of applause for what we have achieved. Okay. So thank you very much. Without wasting much time, we'll just start off the program, and the moderator of this particular session is going to be Dr. Pasanti. So she is going to take over from here. Pasanti, over to you. The lights off cheyali. This is your color light.
Good evening, everyone. So, as Dr. Satish has already briefed about the institute, I would not take so much time. But as we all know, that Anand Eye Institute was founded back in 2001 as a Vitreoretina Institute with a vision to be a center of excellence for complete eye care and to be a forerunner in the research in ophthalmology and impart the best of the advanced practices to the patients. Abiding to these core principles, AEI has gained the trust of many general ophthalmologists who aim to provide good and ethical multi-speciality care to the patients. Also, AEI believes in shaping up competent ophthalmologists for our future generations. Hence, we have active involvement in training and research activities. We have trained till date 6 Vitreoretina fellows, 4 cornea fellows, and 8 DNBs who have come out with flying colors and are flourishing in their individual practices. Our chairman, Dr. Ramesh Ayala, and director, Dr. Satish Agraharam, have played a key role in inculcating the right OPD practices and instilled ethical values in them. And as a team, we are all proud to be a part of such team. It takes a lot of effort, dedication, and passion to build an institute that multiplies in its growth to such an extent that it continues successfully for years together. So here we begin today's session with talks from our budding eye specialists who are getting trained with us currently in the institute. They would be presenting to us their respective research works. So over to Dr. Deeksha, who is going to present her research.
Thank you, ma'am.
Shaima, you pull that up. Pull down. Pull it down. Pull that screen down. Pull it down. Pull it down.
Just drag it down, Shaima.
Drag it down, Shaima. That's all. Okay. Yeah, fine. Perfect.
Good evening,
Somebody
everyone.
has switched on their. It's not the mic.
You have to use the mic.
Ah,
Good evening, everyone.
Speak into the mic.
Good evening, everyone. I'm Dr. Deeksha, pursuing secondary DNB. My ongoing study is comparison of accelerated corneal cross-linking treatment in pediatric and adult age groups for progressive keratoconus. My guide is Dr. Tarana Mansuri ma'am, and co-guide is Dr. Karthika ma'am. Keratoconus is a bilateral, progressive, and non-inflammatory corneal degenerative disease that causes bilateral, progressive, and non-inflammatory corneal degenerative disease that causes irregular astigmatism and visual impairment as a result of the steepening and thinning of the cornea. It has a progressive growth in the pediatric age group compared to the adult age group. Our aim is to compare 6 months result of the accelerated corneal cross-linking treatment for progressive keratoconus in pediatric and adult age groups. Our primary objective is to compare best corrected visual acuity, and secondary objective is to compare maximum keratometry, Kmax, SIM K1, SIM K2, corneal thickness at the thinnest point, and corneal astigmatism. A study is prospective study being conducted at our institute, and which includes patients who underwent accelerated C3R at our institute. Considering pre and post mean values of reference study, the minimum sample size is 50 subjects. Inclusion criteria for the pediatric group: progressive keratoconus and age less than 17 years, corneal pachymetry more than 400 microns at the thinnest point, with the normal corneal endothelium, maximum corneal curvature less than 16 diopters, and patients who are willing for follow-up. For adult age group, criteria is same except the age more than 17 years. Exclusion criteria for both the groups: corneal thickness less than 400 microns at the thinnest point, history of herpetic keratitis, central or paracentral corneal opacities, prior corneal surgeries, severe dry eye and ocular surface disorders, concurrent corneal infections, and the concomitant autoimmune diseases, pregnant and nursing women. Now coming to corneal collagen cross-linking. Keratoconus is an ectatic disorder, so we are doing C3R to increase the biochemical rigidity, reduce the cornea stiffening and central flattening. The concept of treating ectatic corneal disorders with C3R was first postulated at the University of Dresden by Sperrel and Seeler. These are few clicks taken in our institute while doing C3R. And C3R first will remove the epithelium, and the second will soak the cornea with the riboflavin 0.1 solution for every 2 minutes for 20 minutes. Then we'll apply the UVA light at 365 nanometers. Dresden protocol will apply UV beam of 370 nanometers wavelength at 3 millivolt for square centimeters for 30 minutes. Then coming to the photoaccelerative cross-linking, there is a photochemical reaction between the UVA and the riboflavin, which will form the riboflavin singlet state and riboflavin triplet state. In the presence of the oxygen, singlet oxygen will form, and the absence of oxygen, it will form the riboflavin radicals, and which in turn leads to formation of the covalent cross-linking bonds. Coming to accelerated cross-linking, it's based on the Bunsen-Roscoe law of reciprocity. The effect of photochemical reaction is directly proportional to the total energy dose, regardless how the combination of the time and power are distributed. Photochemical effect will be similar as long as the total fluence remains constant. These are accelerated C3R protocols. 9 millivolt per square centimeter for 10 minutes we are using in our institute. This is my master chart. There are very few comparison studies for accelerated corneal cross-linking. This is one among them. Behruni et al. They compared 1 year results of the accelerated corneal treatment for progressive keratoconus in pediatric and adult age group. He included 32 eyes of 32 pediatric patients and 32 right eyes of 32 adult patients. And they concluded a slight tendency toward more flattening in the adult group 12 months after accelerated treatment, but this is not statistically significant. Alifor et al. They concluded, they evaluated the visual and refractive topographic outcomes of accelerated C3R cross-linking in a pediatric age group, and they included 89 eyes of 56 patients with progressive keratoconus, and they concluded accelerated C3R increases visual acuity and stabilizes or improves the keratometric indices in pediatric patients with progressive keratoconus without any serious complications for a mean follow-up time of 16 months. Ozugran et al. They compare the efficacy and safety of accelerated corneal cross-linking in pediatric patients with progressive keratoconus. They included 44 eyes of 38 pediatric patients with progressive keratoconus, and they concluded accelerated corneal cross-linking halted the keratoconus progression without relevant side effects in pediatric patients over 24 months follow-up period. Visual acuity, keratometric values, and corneal aberrations also improved. These are my references. Thank you.
So that study is not started yet.
It started, sir. We as of now we collected 3 patients, sir.
And do you have any results?
Yes, sir. Best corrected visual acuity is increased in the 2 patients, sir, and the 1 patient has a stabilized visual acuity, sir.
So that's in the pediatric group or adult?
One has an adult age group, it is increased, sir, and the pediatric also visual acuity is increased, sir, and the one has a stable, sir, the pediatric group.
So next year this time when I come, you'll have the results.
Yes, sir. I'll
So
have.
there's no study comparing the pediatric to the adult?
There are very few studies, sir. One I.
Okay. What's the youngest you can treat? I don't do this, so I'm trying to learn. What's the youngest age that you can treat? Is that generally accepted? So you can't. And how young do you detect keratoconus in this case? So by the time they are the birth, 7 or 8 years. So you can start treating the cross-linking. So one of my colleagues, John Jorsted, I don't know if no, I don't need it. One of my colleagues, John Jorsted, who's in my department, he proposed using oral riboflavin. It's instead of doing the cross-linking, which is so expensive. So he ran an experiment where he started. So what happened, the story he tells me is this. Back in the day when somebody came with severe headaches, he read somehow that riboflavin can work for headaches or no, I think it's the reverse. So he thought, why not take riboflavin orally and walk in the sun? So that's how he started doing this, and he has a particular dosage that he uses, very high dose of riboflavin. So the patient is supposed to take the riboflavin, walk for half an hour in the sunlight, and he showed actually that the cornea stabilizes just by taking riboflavin orally and walking in the sun for 30 minutes. And one of his patients came back to tell him that she had intractable migraine and nothing worked for migraine. But after she started doing this for her cornea, the migraine disappeared. So now he's running a study on migraine and riboflavin. All the patients that are coming to our practice now, we're sending them back with oral riboflavin, and it seems to be a simple thing. It's zero cost to it's not expensive. Oral riboflavin is very cheap. So my 2 cents on, I don't do it, I don't do this science, but I remember John telling me about this. Thank you, that was wonderful. So hopefully next year you'll be able to do this.
Enable it, just
Over the upper left.
just enable it. Zoom share ಐತಾ? नीचे शेयर
Good evening. Good evening. I'm Dr. Memuna. I'm presenting my research work on a role of patching versus atropenization in amblyopic children. My guide is Dr. Taranum Mansoori. So amblyopia or lazy eye is unilateral or less commonly a bilateral reduction in the best corrected visual acuity that cannot be attributed to any structural abnormality of the eye or visual pathways. The worldwide prevalence of amblyopia is 1.36%. Amblyopia treatment is most effective during critical childhood period of visual development. Hence, pediatric vision screening is of paramount importance. In the early postnatal period, there are critical periods of visual cortex development when the visual system is more vulnerable to any abnormal input in the form of visual deprivation. The upside to it is this is the time when the visual system plasticity allows for greatest opportunity for amblyopia reversal. Coming to the types of amblyopia, we have strabismic amblyopia, where there is a deviation of one eye and the deviated eye loses the focus on the retina. And then a refractive amblyopia, an isometropic amblyopia, isoametropic amblyopia, where there is a bilateral high refractive error resulting in bilateral amblyopia, and visual deprivation amblyopia resulting from any media opacities, congenital cataracts, etc. So in our study, it's a prospective study where 60 amblyopic children coming to the pediatric OP of Anand Eye Institute were taken in the age groups of 5 to 13 years. They were divided into 3 age groups of 5 to 7 years, 8 to 10 years, and 11 to 13 years. They were followed up, the visual acuity was measured, and they were followed up for a period of at regular intervals of 3, 6, and 12 months. The aim of the study is to compare the results of amblyopia therapy with patching and comparing it to atropine penalization. The primary outcome measured would be improvement in the best corrected distance visual acuity. The secondary outcome would be the improvement in stereopsis. By appropriate statistical methods, the sample size was determined to be 20 per group. Yeah, in the similar studies, according to Sheen Park et al., on their study of current management of childhood amblyopia, it was concluded that amblyopia is reversible with appropriate timely management. And Sheeman et al. In their study in 2008 concluded that a treatment with atropine or patching led to similar degrees of improvement among the 7 to 12-year-olds with moderate amblyopia. And Menon et al. In their study for the Journal of American Association of Pediatric Ophthalmology in 2008 concluded that in children of 8 to 20 years with anisometropic amblyopia, both patching and atropine therapy improved visual acuity. And Shen et al. In their study for the amblyopia treatment studies conducted in 2016 concluded that for the management of amblyopia, optimal refractive correction, occlusion prescribed secondary to gains by optical correction, and then patching is started at 2 hours per day and increased if required. So for our study, the inclusion criteria were age of 5 to 13 years, and those having amblyopia, whether uniocular or binocular, refractive amblyopia, and anisometropic amblyopia, isometropic amblyopia, and according to the intervention, those given patching and those given 1% weekend atropine were included in the study. Those excluded from the study were age less than 5 years and more than 13 years, those having any deviation, that is strabismus, any stimulus deprivation amblyopia such as congenital cataracts, any previous ocular surgeries done, and those kids with a neurological delay, developmental delay or neurological abnormalities were excluded from the study. So materials and methods, visual acuity was measured with Snellen's chart, and stereopsis was measured with stereopsis tests such as random dot tests, Titmus fly tests, etc. And coming to the technique of intervention, at the first visit, full spectacle correction was given. At a 3-month review, we noted for any improvement in the visual acuity. If at all there was no improvement in the visual acuity, occlusion of the sound eye with patching for 2 to 3 hours a day was started. Along with patching, 1 hour of near work was prescribed. The other group had weekend atropine, 1% weekend atropine penalization of the sound eye. And again, visual acuity and stereopsis was measured at every 3 months, 6 months, and then 12 months visit. So this slide shows the pirate eye patch or the occlusive patches or the ones covering the spectacles. So this is how the occlusion therapy was being demonstrated to the patients. This is 1% atropine drops given every weekend. So after appropriate statistical analysis, the data was analyzed. Data is analyzed by Microsoft Excel and statistical software, and it is summarized by mean and standard deviation for continuous data and percentages for categorical data. We compared the two groups in each age group by chi-square test or Fisher's exact test for categorical data, and all p-values less than 0.05 would be considered as statistically significant. So this is my master chart showing the students, the patients incorporated in the study. Yeah, these are my references.
So you have not analyzed your data?
The study is still underway, sir. We have collected and given up for statistical analysis. It's almost done.
How many cases have you collected?
I've collected 52 cases, sir.
You have a lot of patients. You should have done at least a preliminary analysis, right?
Yes, sir.
Presentation, but yeah, thank you for the effort. I don't know much about the subject. No, don't give it to me. I don't know. I'm not an expert. Ask your
Unfortunately, pediatric ophthalmologist as well.
So I think who's next? Dr. Shaima Salim would be taking over.
Good evening, everyone. Myself, Dr. Shaima. Good evening, everyone. Myself, Dr. Shaima, and pursuing primary DNB at Anand Institute. My study is regarding comparison of invasive and non-invasive tear film breakup time and its correlation with Schimmer's test 1 in normal and dry eye patients. And I would acknowledge my guide, Dr. Aruna Kumari. Tear film is the first optical interface between the air and the ocular surface. Any disturbance in its structure affects the quality of vision. Then tear film has 3 layers, the closest to the cornea being mucus, followed by the aqueous, and then the outermost lipid layer. The tear film can be assessed qualitatively by tear film stability, for which the tear film breakup time is done. The tear film breakup time is the time interval from the last complete blink to the appearance of the first break in the tear film. It can be done manually by applying the fluorescent dye over the cornea, it can be measured manually using the slit lamp, or it can be done non-invasively without instilling any dye, and the machine measures maps the location of the breakup areas. Then for the quantity, the aqueous tear film production is checked by Schimmer's test, in which the type 1 is done without using any topical anesthesia. It gives us the basal as well as the reflex tear secretion, and the type 2 is done with using the topical anesthesia, hence gives only the basal secretion. Our study aims to determine the reliability of non-invasive method for tear film stability using the Sirius topographer machine. Primary objective is to compare the non-invasive tear film breakup time with the manual fluorescent TBUT in normal and dry eye patients. And secondary objective is to correlate both the non-invasive and the fluorescent TBUT with the Schimmer's test 1. It is a cross-sectional study being conducted at our institute, and the study population includes 50 asymptomatic outpatients and 50 symptomatic patients in the respective groups fitting the criteria. Based on the previous studies, the minimal sample size for this study was calculated to be 50 in each group. The inclusion criteria for the normal group is asymptomatic patients with ocular surface disease index of less than 13, or and for dry eye group, symptomatic patients with ocular surface disease index of more than or equal to 13. The exclusion criteria includes any history of ocular trauma or eye disorders which affects the integrity of the tear film, or the patients using anti-glaucoma medications, or in having any recent ocular surgery, or history of contact lens usage, or the subjects who are unable to complete the questionnaire or understand the procedures. The ocular surface disease index questionnaire will be given to all the subjects participating in the study, and it will be asking 12 questions based on the symptoms, and the response will be given in the graded form as 4, 3, 2, 1, depending on the frequency of the symptoms. Then the cumulative score is applied in this formula, and the OSDI score is calculated. Then the subjects are divided into normal and dry eye based on the score. Then both the groups will undergo non-invasive TBUT, then the Schimmer's test 1, and then the fluorescent TBUT, depending on going from the least to the most invasive, giving a gap of 10 minutes in between. Then the data will be collected and analysis will be done. For non-invasive TBUT is done using a Sirius topographer, which is a Scheimpflug Placido-based videokeratograph, which projects an infrared ring illumination over the cornea based on the Placido disc pattern. And it measures the non-invasive tear film breakup time, analyzing the change in the edges of the reflected Placido mirrors. The resultant map is a chord map, the first showing the dynamic map with a videokeratoscopy showing the disruption of the mirrors. Then the second is a color-coded map depending on the percentage of the tear film broken in the areas. Third is the tear film broken areas along with the real time mentioned over it. Fourth is the graphical presentation showing the time in seconds on x-axis and the percentage of broken tears on the y-axis. Then it gives us the values for the first non-invasive TBUT as well as the average value of non-invasive TBUT. For fluorescent T-bud, the ocular surface is stained using a sterile fluorescent strip with, moistened with the saline, and the stained tear film is evaluated under the broad beam with a cobalt blue filter of the slit lamp. The tear film appears to be green in color, whereas the breaks in it appears to be the black lines or the spots. Then fluorescent T-bud is recorded in seconds in a stopwatch whenever the first break is seen. The Shimmer's test 1 is done by placing the sterile Shimmer's test strips over the lateral 1/3 of the lower lid margin for 5 minutes without placing any topical anesthesia. An amount of wetting of the test strip is recorded. Then I would like to quote few of my reference studies. Hong J et al. Has concluded that the measurements of the non-invasive T-bud using the corneal topographer provides a simple non-invasive screening test for the dry eye with acceptable sensitivity and specificity. TFOS DUCE 2 has indicated that the non-invasive tear film breakup time less than 10 seconds gives the diagnosis for the dry eye disease. And the Ozolten et al. Demonstrated that the Shimmer's test results were statistically significant, correlating with the slit lamp T-bud as well as the non-invasive T-bud done by serious topography machine. This is my master chart indicating the dry eye group in red and the normal group in green. These are my references. Thank you.
No, the good thing about this study, I think that's what I was talking to Anand. I think Anand, you can just tell them why this mission is so.
Sir, first of all, it is the non-invasive method, so we need not, that is the main criteria for this. And the thing is, the sensitivity of this test is also more than the invasive thing. Right now, we didn't analyze, but just gross look at the, can you show the master chart? We can see that the non-invasive T, but that is the serious topographer is picking the dry eye more faster than the invasive T, but because this manually we need to click, we need to see the time, so that hereafter when we get the results, we think that we can, for a dry eye evaluation, that will be one of the modality of investigation.
It's more objective, I think it looks, because it's able to pick it up much sensitively.
So this test picks up, does it differentiate between meibomian gland dysfunction versus aqueous production dysfunction versus mucus dysfunction?
No.
No.
That will be done by the different tests like Shimmer's and the T-bud. Those both are, the T-bud mainly takes up the meibomian gland function, while the Shimmer's takes up the secretion, amount of aqueous secretion. So aqueous dependent or the lipid deficient here, evaporative dry eye can be divided according to different tests.
Yeah, I mean, you know, dry eye is probably the most common eye problem in the world that patients complain about, but we don't want to hear this complaint from the patients because we don't know what to do with this. I mean, patients come.
While the screens are more.
Yeah, I mean, it's such an unfortunate situation, especially as patients grow older. They all complain of dry eyes, and we're like, don't come to me. There's no surgery involved here. Put some artificial teardrops. Do you know that? Do you know, Taranam? There's no analysis of all the dry eye products in the market. Nobody has done a scientific study of actually what is this dry eye product made of, and does it really help the patients? There's nobody has looked at it. We developed a surface tension modeling in our lab, and we are actually collecting data on the contact angle, which is what, when you put a drop in the eye or any surface, there's a contact angle. Depending upon the contact angle, it will tell you how long this solution or a drop or whatever you're going to place on the surface is going to stay on it. It's like if you take lotus leaf, you put a drop of water, what happens? It doesn't stick to it, right? It runs off. It's to do with the surface tension and the contact angle. On the other hand, you take a wet cloth and you put it on it, it absorbs it. So we are actually in the process of completing this study where we are analyzing the contact angle of all the various products like Systane, Refresh, and different products that are there in the market. This requires a lot of studies. Dry eyes, I mean, I think we're going to focus on this in the next 3-4 years to come out with better understanding of dry eyes. But for the future budding practitioners, this is something that affects so many people, yet we don't pay attention to it, unfortunately. I think a lot of research needs to be done on this area. This is one of the gap areas in ophthalmology.
Thank you. Ramya.
Good evening everyone, this is Dr. Ramyapriya Jagadisan and my study is on comparison of subjective astigmatism and topographic astigmatism in myopia under the guidance of Dr. Aruna Kumari. Myopia is a dioptric condition in which the parallel rays of light focused anterior to the light sensitive layer of the retina when the accommodation is at rest. Astigmatism is that a condition of refraction where a point focus of light cannot be formed on the retina. The aim of this study is to compare between the subjective astigmatism and topographic astigmatism in myopic patients, and the objective is to determine the correlation between astigmatism measured with serious topographer and subjective refraction in myopic patients. This study is a prospective comparative study that will be conducted in Anand Eye Institute, Apsiguda. The study population includes the outpatients who are presenting at our institute. The sample size will be determined by the reference article, and the minimum sample is 239 eyes calculated by using the PAR t-test formula. The statistical analysis will be done by Microsoft Excel and statistical software, and the categorical data will be calculated by using chi-square test, Fisher's exact test. The patients with myopia and aged between 18 to 40 years of age are included in this study, and the patients who are aged less than 18 years or more than 40 years, patients having corneal pathologies like hepatic eye diseases, keratoconus, severe ocular surface diseases, glaucoma patients, collagen vascular diseases will be excluded from the study. The methodology is every patient will be undergoing uncorrected visual acuity by using the Snellen's chart. Then the objective refraction will be done by using the retinoscopy, following the subjective refraction by trial and error method, followed by the slit lamp examination, and finally the topographical analysis will be done by using the Sirius Scheimpflug Placido based video photograph. The cylindrical power and the axis from the subjective refraction and the topographical analysis will be compared. Wu et al. Made a study on correction of the myopic astigmatism with topographic guided laser in situ keratomiliosis, and he has kept two groups. The primary group of by using the subjective refraction, and the enhancement group which includes topographic guided, and he has concluded that the TopoLink has shown higher predictability and efficacy for the retardation of both primary and postoperative irregular myopic astigmatism. Canalopoulos has studied a topographical modified refraction, the adjustment of treated cylinder amount and access to the topographic versus standard clinical refraction in myopic topographic guided LASIK, and he has kept 50 patients where the one eye is done with subjective refraction and the contralateral eye will be done with the topographic guided, and he has concluded that TMR, when different from the clinical refraction, may offer superior outcomes in topographic guided myopic LASIK. This is the master chart of my study and these are my references. Thank you for everything.
Sir, any questions? So basically, there is no paper comparing the subjective astigmatism and the topo-guided astigmatism. And studies are there where the refractive surgery were done. So the aim, this is a part of the study for her thesis. Here she will be comparing the topography with the subjective. But later on, we are planning to give the whatever is the objective astigmatism the patient is getting in the glasses, spectacles, and then we want to see how he is accepting, and then if the patient is ready to get a surgery for the refractive surgery, as these we have these two reference, 2-3 are there, so we are planning to do one eye with subjective astigmatism and the other eye with the topo-guided astigmatism, and over the time we want to see the result compare. This is a part of a thesis right now. If you have any.
So the concept here is like this, sir. So normally we give only subjective astigmatism as a correction, isn't it? But there are papers which are telling you that the objective astigmatism, what is seen by topography, is what being corrected by the LASIK. So they say that they have a better result. But in India, actually, I think, Dr. We are doing only subjective. They don't do objective.
If in topography, if the astigmatism is around 1.5 and the patient is accepting only 0.5, we are correcting only 0.5. But after the surgery, patient is accepting that 0.5 or -1 after the surgery, not before the surgery. Few patients, not everyone. They are happy because they will be free of glasses. But when we take our objective correction, they feel that when we give this objective correction of topography, they are feeling more better even after surgery.
So objective is better than the subjective?
Yeah, no, sir. Before surgery, I am correcting subjective.
Right.
But after surgery, they are accepting the cylinder which they were not accepting before. Yeah.
Okay.
So till now we are doing only subjective correction.
Right.
Now we don't have a data telling how people accept objective, topographic based astigmatism.
Right. Yes.
We are giving only subjective. Topographic, suppose when you do a retinoscopy and you find 4 diopters, you are actually, if the patient is accepting only 2 diopters, topography is saying 4 diopters, topography is saying 4 diopters. So we need to know what is the data in the Indian population. That's what these people are trying to do.
Okay.
They have around about 240 patients. 240 patients is a reasonably decent number for us to tell us what is the acceptance. And later they can extrapolate it into and say that you can actually do only topographic guided astigmatic correction that will become better.
We want to extend this study.
Yes.
First, give the objective astigmatism in their spectacles. Let them use for 3 to 6 months. Then come back. Then we have a few ideas. So I think over the time we'll try to give that.
Yeah, next year we'll have the full results, right?
Sure.
Very nice.
Pallavi.
Madam want to ask. Dr. Mama.
Aruna, is it like that in children we have to give full astigmatism correction and in adults it is little less? If acceptance is not there also you have to give full correction in children and in adults it is little less. Is it?
So madam, your question is in children we will give full correction? Yeah, in children, in pediatrics. In children we give. In adults, we don't give, but when we do a refractive surgery, the patients sometimes they are not accepting the topographic astigmatism. So we give subjective astigmatism. That for children, we give objective correction only till the age they do not read or they do not read it, the things, the Snellen chart. Once they start, yes. Later on, we give whatever they accept.
I think the study is not including children, right?
This is in myopes. This is in myopes more than 18 years and less than 40 years. This study.
This is only for patients who qualify for LASIK procedures.
Go ahead, Pallavi. You have to use this.
Good evening, everyone. I am Dr. Pallavi, VTU Retina Fellow. Today I am here to present our study on OCT prognostic indicators of macular hole surgery. Various OCT biomarkers predict outcomes of management of macular hole. Long-standing macular hole often have poorer visual prognosis, which is a well-known fact. This is the OCT picture showing the full thickness macular hole. Factors which predict visual outcome in macular hole are duration of disease, macular hole base diameter, macular hole height, and presence of intraretinal cyst. Our objectives were to assess the effect of duration of disease on postoperative visual recovery in macular hole patients, and to evaluate the correlation between OCT biomarkers and postoperative visual recovery. In our study, patients with diagnosis of idiopathic full thickness macular hole were included, and the patients with post-traumatic macular hole and with previous retinal surgeries or intravitreal injections, they were excluded from our study. Ours is a retrospective study conducted on 25 eyes of 25 patients. Among them, 8 were male and 17 were female, who attended to Retina Clinic, Anand Eye Institute, with diagnosis of macular hole from June 2021 to December 2023. Clinical characteristics including age, gender, comorbidities, and disease duration were recorded at baseline. Best corrected visual acuity was recorded at baseline and day 60. OCT scans were performed on OptoView, RTView, SD-OCT at baseline. OCT biomarkers, namely macular hole base diameter, macular hole height, intraretinal cystic changes, and size of intraretinal cyst were recorded. Descriptive statistics, Pearson's correlation were used when appropriate. For statistical analysis, statistics SAS version was used. In our study, among 25 patients, minimum duration of disease in months was minimum was 1 month and maximum was 12 months. Macular hole base diameter, minimum was 200 microns and maximum was 3160 microns. Intraretinal cyst size, minimum was 150 microns and maximum was 855 microns. Macular hole height, minimum was 185 microns and maximum was 931 microns. Among 25 patients, 16 patients had intraretinal cyst, whereas 9 patients, there was an absence of intraretinal cyst. This is the OCT picture showing how we calculated all these parameters. Macular hole base diameter was calculated as a horizontal distance between the retinal pigment epithelium, and the macular hole height, the distance between the retinal pigment epithelium and the inner edge of the macular hole. And the largest intraretinal cyst size was recorded. Decreased logMAR indicates that recovery is improvement is present in visual acuity. Among 25 patients, 20 patients presented with a duration between 0 to 6 months. They had mean preoperative best corrected visual acuity 1.083, which improved to 0.768 postoperatively. 5 patients who presented with duration of disease between 7 to 12 months presented with mean preoperative best corrected visual acuity 1.296, which was improved to 1.063 postoperatively. Among 25 patients, 10 patients had macular hole base diameter as less than 1000 microns with mean preoperative best corrected visual acuity as 1.146, which improved to 0.822 postoperatively. 15 patients had more than 1000 microns macular hole base diameter, presented with 1.112 mean preoperative best corrected visual acuity, which was improved to 0.850. These are the scatter plots which were plotted between disease of duration in months and postoperative visual acuity. the base diameter in microns and postoperative visual acuity, intraretinal cyst size and postoperative visual acuity, macular hole height in microns and postoperative visual acuity. These plots showed that increase in duration of disease and OCT biomarker size resulted in decreased postoperative visual acuity. So in all these cases, Pearson correlation analysis was done to know the significance. Significant correlation was found between duration of disease, macular hole base diameter, intraretinal cyst size and postoperative visual acuity, as the p-value for all these cases was less than 0.05, whereas no significant correlation was found between macular hole height and postoperative visual acuity, as the p-value was more than 0.05. This is the master chart showing the details. Discussion. We evaluated the role of duration of disease and preoperative OCT measurement in predicting functional outcome after macular hole surgery. In our study, as duration of the disease increased, visual acuity decreased. Similar findings were concluded by Murphy et al. Murphy et al. Conducted a study on the effect of macular hole duration on surgical outcomes. They concluded that symptom duration was independently associated with both anatomic and visual outcomes in persons undergoing surgery. And as the macular hole size increased, the postoperative visual acuity decreased. Similar findings were found in the Ulrich et al., who conducted a study on macular hole size as a prognostic factor in macular hole. Intraretinal cyst. As the intraretinal cyst size increased, the postoperative visual acuity decreased. This Unnikrishnan Nair et al. Also concluded that intraretinal cyst size has an effect on postoperative visual acuity. Conclusion. Early surgical intervention should be done as duration of disease is associated with visual outcomes in persons undergoing surgery for macular hole. Preoperative OCT measurements of macular hole base diameter has good predictive value for functional outcome of macular hole surgery. Intraretinal cystic changes in various retinal layers correlate with visual outcomes in macular holes. These are my references. Thank you.
So I think one of the important things about, first of all these 25 holes, they have closed. So we're talking about closed macular holes, the visual acuity, not unclosed macular holes. So important thing what we actually tried to look at in this particular study was, we really wanted to know how important was the base diameter. Actually, if you can go back into your slides, go back and into the visual results slide. Yeah, stay there, back. Go back. Yeah, stay here. Now, if you actually look here, if there is a difference between the bottom one, the 10 eyes and the 15 eyes, the mean improvement in the vision postoperatively is almost the same, in spite of the fact that was a 1000 micron. The reason why this has occurred is basically because the duration of the disease has made a difference here. The duration of disease was shorter in this greater than 1000 micron one, slightly shorter in few of these patients, and that's why we got a lesser mean postoperative one, and that is trying to show. But when you actually look into the log, the raw data, you'll actually find that the bigger holes have got lesser visual acuity improvement. Okay. And so these, of all the factors, there are only two very important factors which actually affect us, the macular hole. One is the base, the diameter of the base. The second one is the duration of the disease.
So question, I'm not right now a person at all, I don't deal with this. How do you know, how do you decide the duration? How do you know when the macular hole happened?
Yep.
Just symptomatically from the patient's history?
Yeah, first thing is, see, predominantly it is we ask the patient about the symptomatic history, but it's very unlikely to match the symptomatic history with the duration of the hole. Right. One of the pointers which we look is the clinical appearance of the hole. If the clinical appearance of the hole is showing, the edges of the hole is showing cystoid changes, if the edges of the macular hole is showing cystoid changes, if you find a retinal pigment epithelial atrophy at the base of the hole, and if you have an underlying small area of choriocapillary loss, this indicates that that hole has been there for more than 6 months to 1 year. That tells you the chronicity of the hole. Fresh macular holes, you will rarely see fluid accumulating in the intraretinal. That's where your OCT comes into picture. So a good clinical examination and when looking at the OCT will actually give us a better picture.
So
how long?
The duration is an objective assessment, not a subjective one.
Absolutely, absolutely.
And you can distinguish only before 6 months and after 6 months. You cannot pinpoint and tell me this is 2 years old, this is 10 years old.
Very difficult, very difficult.
Okay.
And often the patients usually land up in the problem with a good eye where they have at least some redness or some small problem in that particular eye. They try to rub that eye and close that eye, and suddenly they realize that the other eye they are not able to see. And that's how they actually walk. And they come and tell us the history. Last week only, sir, I closed. Then you ask them, how did you see? Then they will say, there was a power cut and I tried to close one eye and then suddenly the other eye is come. Okay. Thank you, Pallavi.
Very nice. Yeah, there is also there. So any new surgical techniques are developed for macro?
Sir, now we don't practice island peeling at all. I just do a small area of island screw into the hole. I don't peel from arcade to arcade.
So you
Just
peel
peel
the
it.
thing and then fill the hole?
And we don't, see what we do is, we peel around about, say around about 30-40 microns away from the hole and we push it into the hole. The edge will be, the hinge will be around the hole.
Okay.
So it just scrolls because the island has got a capacity to
It's
scroll.
like a medical graph.
It's like a graph, but
Yeah.
it's a like a 360-degree graph.
Uh-huh.
So it will just fold like, petals of a flower.
And with time it will close the thing?
Day one itself you will see the hole is closed because the island what it does is it has got an intrinsic capacity to scroll just like your desk pens. When it scrolls, it pulls the edges of the hole together. So within a couple of days actually you will see the hole is closed. Maximum. So within 24 to 48 hours.
Vision improvement takes longer though.
Vision improvement, distance vision correction improvement will be minimum. Like for example, we operate a patient who is 636, 624. They may go up to 618 or 612. But significant improvement in vision is in the near vision. The patient says that I was not able to read big, I was able to see only N18 or N36 before. Now I am able to go up to N9. In spite of the fact that the distant vision has improved to 618, 612 only. Because you are getting the fovea closer. That is exactly what is happening. So macular holes will always, so we don't follow the ILM peeling technique even for a 200, the smallest hole what we had was 200 microns. 200 microns holes also we do a small ILM peeler with it. So the standard protocol which people follow is up to 500 microns, up to 1000 microns they peel the entire ILM and wait it for it. Whatever be the size of hole irrespective is scroll. And our results are as good as around about 98% of the holes do get closed. Suppose if you get a hole which is not closed before, then we have various techniques. Like you put some blood clot in there, you peel ILM from outside the arcade and push it into the hole, stuff it. There are so many other techniques. You can even take a punch graft of the retina and put it in the center.
Equivalent to this is in the surface of the eye we use amniotic membrane.
Correct.
So do you guys have
They even put amniotic membrane also. People have tried amniotic membrane. And people now are trying for very large holes which are 2500, 3000, which are very difficult to bridge by these kind of things. They are cutting an area of retina outside the arcade, and they are putting it in the central area. They are doing a fluid gas exchange and leaving it and it is sticking. What was very interesting thing is the central part of the fovea is only cones. What we are cutting out of the retina in the periphery is only rods. Beyond the arcades, it's only rods. In spite of the fact that the rods are kept in the center, there is some anatomical modification which is happening over a period of 6 months to 1 year, where the patient is from 2/60, 1/60 vision, the people are able to go to 660, 636. And they are able to perceive color. Why is that happening? Why a rod is behaving like that? None of us are. And they have done an ERG also to actually find out whether the central macular function is, the central macular function which is practically nil has become just subnormal, which is something which is very interesting. And the retina graft which is put has got joined to the surrounding retina, which is quite interesting.
Okay. Good evening. I'm Dr. Shweta, pursuing fellowship in cornea department. I would like to present a pilot study conducted on comparison of astigmatism and higher order aberrations in cone ablation plus collagen cross-linking versus collagen cross-linking alone in keratoconus under the guidance of Dr. Anupama, a cornea consultant. So we all are aware of the fact that collagen cross-linking is a standard procedure for halting the progression of keratoconus. So apart from halting the progression, we can also improve the quality of vision with an additional procedure like phototherapeutic keratectomy. So ours was a pilot study conducted at our institute, and we included patients with progressive keratoconus whose thinnest pachymetry was more than 420 microns. And those patients had poor rigid gas permeable contact lens fit, and they were unhappy with their glasses. So all the eyes were imaged with serious topographer. Since the epithelial thickness in all the keratoconic eyes was non-uniform, it was removed manually. Phototherapeutic keratectomy was performed by optimized refractive keratectomy PTCAM software on corneal wavefront profile using Schwinn MRS. Our main objectives were to assess the best corrected visual acuity, the spherical and cylindrical error, the maximal anterior curvature, and the root mean square of higher order aberrations, with the follow-up ranging from 3 months to 1 year. So this is the machine which we used, and so this is Schwinn MRS. It uses the flying spot technology for excimer laser and uses the wavefront guided optimization. So as we can see here, it ablates only a particular area of the cornea, that is only the cone region. So we collected 6 patients and divided them into 2 groups. So the first group was subjected to accelerated collagen cross-linking only, whereas the other group was subjected to accelerated collagen cross-linking with PTK shaping. So coming to the procedure of accelerated collagen cross-linking, we de-epithelialized the central 8 mm of the cornea. We soaked with 0.1% riboflavin for 20 minutes and exposed it to UV radiation with intensity of 9 milliwatts per centimeter square for 10 minutes with intermittent soaking every 2 minutes using the CL UVR rapid machine. For PTK shaping, we planned with Schwinn Serious topographer. The scans with good acquisition quality and suitable for static cyclotorsion control were chosen. The location of the maximum anterior tangential curvature was recorded. The maximum and minimum diameter of the cone area, which was an ellipse, was manually assessed such that the ablation zone included the steepest zone and extended beyond it by roughly 1.5 to 2 mm. The maximum ablation depth was 20 microns. So this is how this planning looks like. So here we have 3 important sections. Here we can see that the cone is inferiorly placed, it is decentered. So this section includes the depth of ablation, the measurements of the cone, that is the long axis, short axis, and the offset from the center. This indicates the static cyclotorsion control, and this indicates the optical zone that was ablated. So post-operatively, they were treated with topical rotiprednol 0.5% with a tapering dose over a period of 4 weeks. So this is the topographic picture of a reference patient which was included in the accelerated collagen cross-linking alone. So here we can see that the cone is shrinking. So we can see the dimensions of the cone being reduced, and we can also see the flattening. So this kind of response was seen in all the 3 patients. So this is a summary, this is a table of the summary of pre and post-operative eye metrics in the first group, that is an accelerated collagen cross-linking. So here we can see that the K value, the K max is reducing in all the cases. Then coming to group 2, that is PTK shaping with collagen cross-linking, again we can see a decrease in the size of the cone and also flattening. This kind of response was again seen in all the 3 patients. So this is a summary of the pre and post-operative values. So here we can see that along with the flattening of K value, K max, there is a significant reduction in the spherical value and the cylindrical value as well, resulting in an increase in the visual acuity. So on comparison of the first group and second group, we can see that there's a reduction in K max in both the groups, but the vision is significantly improving in the second group, where we have used a combined procedure. So after analysis, we observed that there was a significant improvement in the visual acuity, reduction in the anterior corneal aberrations, reduction in the maximum anterior curvature, and the spherical and cylindrical power in all the eyes which were treated with the combined procedure. So coming to discussion, so in eccentric cones, intracorneal ring segments was the only option where the corneal thickness was less than 450 microns. But with the recent program in Schwinn MRS, we can do a customized ablation of the decentered cone and thus improve the visual quality and the topographical outcome with minimal ablation of the tissue. So our limitations was that the location and spread of the steepest zone was subjectively decided by the operating surgeon, and that large cohort studies with longer follow-up period is required to compare its performance to existing treatment methods. So our take-home points would be that customized ablation centered at the steep-end zone with minimal stromal loss gives good results. Reduced corneal surface irregularity and improved visual quality is seen. A reduction in myopic and cylindrical error can be achieved, and there is a reduction in anterior corneal higher order aberrations too. So this is my master chart, including all the patients. I would like to show a short video. So this is a video of TREC, which is topo-guided removal of epithelium. So there's a slight change, but the planning is the same. So this is how we measure the cone, the long axis and the short axis. We check for cyclotorsion, and then we do, so in TREC, basically first the ablation is done, then followed by epithelial removal. But in our procedure, we remove the epithelium manually, followed by ablation. So this is how the epithelium is removed. And then we followed it with collagen cross-linking, accelerated collagen cross-linking. And this was the procedure done. Thank you.
Very nice. So you're going to continue this study?
Oh, yeah, that's Upama, she is the head of the
This is a new concept, so this is a pilot study that we compared, and the inferior cone was treated only with CXL. There was a flattening, but no improvement much in vision. And this gives both.
Oh, yeah.
Because the scope of CXL is up to 65 diopters most of the time. These are all cones which are more.
So are there any limitations to this technology? Do you exclude out any patient? Every cone can be included in this?
No, sir.
Thickness?
So basically, there's a rigorous patient selection to this procedure. So till now, we have selected asymmetric cones where one eye has high cylinder because of the decentered cone, where we can match it with the other eye. So patient usually not willing to wear complete correction. If he's good with unaided correction, that is enough for him. Then this is the best procedure we're choosing on hand. Pachy comes in and just 20 or 30 microns more than 400, this can be done. So, but the thing is, we have to be sure of the cone metrics in these patients. So central cones or cones which show equal spear and cylinder errors will not benefit much from this procedure. So yes, so because only if the steep point is somewhere inferior, and that is the only thing affecting the sphericity of the cornea, if we can snub it, then we'll be improving the unaided. That is the plan.
I'm guessing Pellucid is not
No sir, no sir, no sir, no sir, no sir.
Yeah, very neat, very neat. Thank you.
Thank you.
One of the most important thing is the unaided visual correction which they are getting. I have seen all our patients. I have seen all our patients, and you can see a smile on their face. And look at the amount of astigmatism which has come down, which doesn't happen with your just a CXR.
Right, right.
And actually, she has more number of patients, and she has a quite.
With follow-ups, we took only 3.
Okay.
Because I have even 1 year plus follow-ups who are coming to me and they're stable. There are more number of patients.
Yeah, you have 9 or
9 patients.
they have all. She has 9 patients in this group actually, but she just wanted to give a good comparison for that, and that's why she has chosen this.
Very nice.
Thank you, Shweta.
Thank you.
Sriram. So there is slight change in the program. After this, I think we'll have the international speakers speaking, and then we'll follow our program.
Good evening, everyone. I am Dr. Sriram, a fellow in Vitreoretina Department, Anand Institute. Today I will be presenting a study on OCT predictors of short-term visual outcomes among various anti-VEGF molecules in macular edema associated with branch vein occlusion. So as we all know, branch vein occlusion is the second commonest retinal vascular disease. Various OCT biomarkers are discovered for predicting the outcomes of management. So factors affecting the anatomical outcomes are like presence of vitreomacular attraction and epiretinal membrane. Factors affecting the functional outcomes are like presence of external limiting membrane disruption, chronic cystoid degeneration, and disorganization of retinal inner layers. Recent retinal vein occlusion guidelines have recommended intravitreal injection of anti-VEGF drugs as the first-line treatment for macular edema associated with branch vein occlusion. So our objectives of this study are to assess the anatomical and functional outcomes to the first anti-VEGF injection and to compare them among the three molecules like bevacizumab, ranibizumab and biosimilar razumab. So inclusion criteria were treatment-naive patients diagnosed of macular edema associated with branch vein occlusion. We have excluded glaucoma and other macular pathologies. So ours is a retrospective study conducted during October 2022 to March 2023 on 30 eyes of 30 patients attended to the retina clinic. So complete ocular examination, best corrected visual acuity and OCT recording were taken at baseline and day 30 after the injection respectively. So this is a slide showing the central macular thickness, how we measure. This is a caliper we use from the summit of the foveal contour to the hyperreflective RP layer, and from the summit of the neurosensory detachment to the hyperreflective RP layer is the neurosensory detachment calculation. And we have identified the largest cyst, and the horizontal diameter of the largest cyst were taken as a measurement of area of large cyst. And this is the OCT showing the disruption in the external limiting membrane. This is the external limiting membrane. The red arrow is showing the disruption of the external limiting membrane and also the hyperreflective foci and the disorganization of the inner retinal layers. So coming to the results, a mean age group of our study was 57 years and the mean duration of the disease is the 31 days, and the injections, 15 injections were given for bevacizumab, ranibizumab, 6 people have received and 9 people have received the razumab injection. The best corrected visual acuity at baseline was 41 letters. So this is a chart showing the best corrected visual acuity improvement among the 3 injection groups. So the red line is showing the baseline visual acuity and the yellow one is showing the improvement at the day 30 of after the injection. So in this slide we are showing the mean best corrected visual acuity is improved in the people with intact ELM, that is external limiting membrane, whereas in the 8 people of our study had the disruption of the ELM, and there is a very little improvement, or there is which is statistically not significant. And coming to the OCT biomarkers, there is a significant decrease in the central macular thickness and area of large cyst and neurosensory detachment in the all 3 groups of bevacizumab, ranibizumab and razumab. So, but among the 3 molecules when we have compared, the p-value is not significant in decreasing the OCT biomarkers. That is telling us that all 3 molecules have a similar response to the first injection. So this is a prototype patient where before injection and day 30 after the injection, the OCT image of horizontal and vertical scan. So OCT markers, they predict the short-term and long-term outcomes post-injection. So in patients with external limiting membrane disruption, there is a photoreceptor death. So this is the main indicator for poor visual outcome. So we can consider external limiting membrane disruption as a sensitive indicator associated with best corrected visual acuity before the treatment. So anatomical and functional outcomes among the anti-VEGF molecules is similar and there is no statistical significance. External limiting membrane disruption is a sensitive indicator for poor visual outcomes. This is my master chart references. Thank you.
I just have one comment. When you show off the master chart, the names of the patients are displayed. I think the HIPAA rules will prohibit that. You should not show the patient's name because broadcasting this through YouTube.
True, sir.
don't want their identity to be known just for the future.
True, sir.
So Avastin is as good as everything else.
That's exactly what I think you all know about the CAT trial. There's a CAT trial, the prospective randomized control study done in the UK. The NHS has said that the CAT is out of the bag. I mean, Avastin is as good as any other drug. And in fact, the biosimilar, what was interesting was even the biosimilar Razumab is also the same. Connect the international speakers. Who wants to talk first? Arun Devgan.
So those were the wonderful presentations from our postgraduates and fellows. So let's move on to the next topics, and here we have the international speakers, and it's our privilege to have the esteemed international faculty, Dr. Uday Devgan, Dr. Arun Devgan, and Dr. Annalisa Arisamonia. Dr. Uday Devgan is an award-winning, internationally renowned expert in the field of ocular surgery, specialized in cataract, lens, and LASIK surgery, and he's the chief of ophthalmology at UCLA Medical Center and a clinical professor at Jules Eye Institute. So he has many accolades and awards and publications attached to him, and he's a man who doesn't need any introduction, and it is our honor to have him here connected with us virtually. So the first presentation, I think, is Dr. Arun Devgan, the virtual reality phone-based visual field system.
You're not a doctor. You're a student.
Oh.
Arun, don't feel like you're a doctor already. Okay?
Not yet. I'm joining medical school next year.
He's applying to medical school.
And the host enables screen sharing so I can share my PowerPoint.
Ask him to share his screen.
Dr. Arun, can you please share your screen?
Yeah, I'm unable to. The host needs to enable screen sharing.
Can you please try now?
It says the host has disabled screen sharing.
Okay.
Yeah, there you go.
Today I'll be presenting on a virtual reality visual field project that I've been working on with Dr. Ayala at the University of South Florida in Tampa. So this project was thought of by Dr. Ayala all the way back in 2002 when he had the idea to create a portable visual field test using a virtual reality headset. And what we can see here is the first ever virtual reality headset from a Korean tech company, which is connected to a Palm Pilot and is using the D'Amato campometer as its method for evaluating the visual field. So the results of this initial pilot study show a sensitivity, specificity, and accuracy all of around 70%, which is pretty good for its first ever iteration. And then the project took a back seat for many years until 2017, where it was reinitiated with this Oculus Rift, which is a new type of headset. I'll play this video so we can see how it works. And the current model, which I'll be showing next, is quite similar to this, where it's a headset the patients run, and then they are in this black environment with a fixation point in the center, and there are dots which are quite dim on the screen, but maybe you'll be able to see around the visual field, and the patient is pressing a clicker every time they see a dot. However, the problem with this iteration is that it's also still quite expensive, which is not accomplishing the goals of our project, which we hope to accomplish next. So the results of this study were also that there's a specificity, sensitivity, and accuracy of around 70%, which we hope to improve upon. So now the current project we're working on is using the same virtual reality visual field technology, but implementing it into a smartphone. This would dramatically decrease the cost of of running this test since people all over the world have smartphones. And this is what our device looks like. You put a smartphone into this plastic headset, which is only $20 on Amazon, and the patient has a clicker in their hand, and this is all that's needed to run the test. So this technology has significantly reduced the cost of the exam. So in comparison, the Humphreys Visual Field Analyzer, which is the gold standard for assessing visual fields, is large, it's expensive, it requires a doctor's appointment with a technician who can run it, but it's very accurate. So we hope that with our test, which is much less expensive, portable, and can be self-administered at home, we have two objectives with this project. We want to create a smartphone-based app that can monitor visual fields for the point of monitoring people who already have glaucoma and they want to stay updated on their own visual fields, and also for increasing screening for glaucoma in populations that have less access to care. So the methods of our study is that patients who are already in clinic for a scheduled ophthalmology appointment with Dr. Ayala were asked to participate in the study if they have recently completed or will soon complete a Humphreys visual field exam. We then move the patient to an empty exam room, and the virtual reality device is set up and placed on the patient. The patient is instructed on how to complete the exam, and the patient then completes the exam, and the results of our test and the results of the Humphrey test were classified by Dr. Raffi as either normal, mild, moderate, or severe. And here are some example fields. On the left, this is the Humphreys printout of a person's visual field, and on the right shows our iPhone app or Android app version of that same visual field. So as you can see, it lines up pretty closely. While there are some random spots, it looks like up here, that's not present on the actual visual field. We'll talk about later why that might be. Here's a mild visual field defect, again, pretty similar. And here's a normal visual field. And the presence of the natural blind spot is an important indicator for us, letting us know that the patient are keeping their eyes fixated at all times. So the results of this study, we tested 98 eyes from 50 patients, and comparing to Humphreys, we assigned those each eye as a true positive, a true negative, a false positive, or a false negative. And using the strategy, we calculated a sensitivity of 96%, a specificity of 55%, and an accuracy of 87%. So, and also our post-test survey shows that our results were very well received from the device. The patients enjoyed the experience and they wanted to be able to use it at home. So the main next steps that we need to do are improve the specificity, because as we saw, our sensitivity is really good, but the specificity is not so high. And this is because we have a lot of false positives where patients who have normal vision forget to press the clicker at certain times, and then deficits in their visual field show up. We think it's likely it has to do with patient attention span, since for patients who have normal vision, the 10 to 15 minute test can be quite long to sit through. So another way we can do that is to be more clear with patients who have maybe a language barrier or are too old. Furthermore, we can introduce a new video to play at the beginning of the test that clearly explains to all patients what they need to do to help standardize that aspect of it. I also believe we need to improve the algorithm of the software with shorter tests for normal patients, so that the device can recognize when a patient's normal and end the test early, and that we should randomize the location and intensity of the stimulus. Test repeatability is currently being worked on by another medical school student, and we also want to start gathering data from patients taking the test at their own home, and we want to create an iPhone compatible app for this technology. Thank you, that's all.
Questions? It's both for screening. I mean, my vision is this. Technology is becoming so expensive. What we are delivering in Anand Institute and LV Prasad and in our center in US, it's restricted to only those people who have the money. You are actually excluding out 95% of the world's population from modern technology. Technology that we have right now is good, and the results of cataract surgery, glaucoma surgeries, retina surgeries, etc., they are so much better today compared to 20, 30 years ago when I started my practice. But along the way, the cost of this is that we excluded, knowingly or unknowingly, 95% of the world's population from this revolution that's taking place. That should not be the case. So the goal is to miniaturize the technology so anybody in the world can have access to the same quality of care or similar quality of care while these patients, while the diagnosis is not missed, right? So the twofold intentions behind this: one, as a screening tool at home for patients. For example, in glaucoma, mass screening has never been proven positive. It's too expensive, too cumbersome. There's no way to screen these patients on a population-based studies. So the idea is those with positive family history, those who are African American descent, Latinos, India, South Indians have a higher incidence of glaucoma than elsewhere. So if we can educate this patient population and they can download the app or using their smartphone, everybody seems to have a smartphone now across the world. So you make this app cheap enough and provide a cardboard technology for the virtual reality goggles, comes for about $5 on Google. You can run the test yourself. Now, the back end of this is that we can actually create software, which we have not done yet at this point, but the intention is to provide for those patients who want to access monitoring their own glaucoma at home. Every 3 months they can do it instead of running to our offices. The incidence of glaucoma, the aging population means that the incidence of glaucoma is increasing worldwide, and it's impossible for the few glaucoma specialists that are existing in the world at this point in time. The United States has only like 1,000 glaucoma specialists. India has, last I know, maybe 200 glaucoma specialists, correct me if I'm wrong. Now, for a billion plus population, 200 plus glaucoma specialists, how far is this care going to go? So, educating the population. What I want to urge all the young students here is this. Think about it this way. Spend your lifetime miniaturizing this technology, minimizing the cost of care so wider population can access this care. That's the whole point of this kind of experiment. So we have a lot of research going on in our center where we are able to miniaturize cataract surgery, the phaco unit. I'm able to miniaturize that into a backpack. Maybe in a couple of years I'll share that kind of technology with you. I don't know if it is going to be successful or not, but in the lab it's working for sure. But this is our first of the kind of app. Arun is actually a student, and he may be interested in coming and working with you, Tarunam, if everything works out, to bring this app here and run the test on your patient population, if you guys are interested in participating with us. And so I thought it would be a cool idea for Arun to take part in this. Thank you, Arun. Wonderful presentation.
So how much time it takes?
Thank you.
How much time does it take? So if you're normal, you'll get bored. That's the whole point of what Arun is trying to say. That's why the specificity is not as accurate as we want. There are a couple of problems with this cheap technology. Fixation. So there's no way for me to monitor fixation. So we're trying to incorporate that into the app itself as to how to fixate. We have not come to a satisfactory conclusion as to how to improve fixation, other than instructing the patient on a website, etc. Right? And two, we do not know, what's the second point I wanted to say? I forgot. Anyway, let's go on to our next speaker, Annalisa Erzamina. She trained with me. She did a residency training at Tulane with me, and she did a glaucoma anterior segment training with me back in 2003. She's a star glaucoma surgeon in the United States. She practices in Miami. I'm so grateful for Annalisa to join our conference here today. Annalisa, people in India at this point in time don't know about Annalisa, but mark my word, you will in the near future. Annalisa, take it on.
Hi, can you hear me okay?
Yeah.
Yes.
Perfect. So I am very happy to be invited here. I think what Ramesh has started has been wonderful. Every time I think, I'm so tired, I have no time, I keep thinking of Dr. Ayala and saying, well, he can run a practice, run a hospital, run a research department, and run a residency department. I think I should be able to have extra time. So let me share my screen and let's see if we can get this going. Can you see my slides okay? Let's start talking about canaloplasty. I am very passionate about this topic. I believe that in glaucoma, if we're able to keep the patient for a long time, we're living too long, people don't die. So if we need to keep them alive and keep them seeing, we need to start early and treat them with something less invasive so we can treat them again. Now, there's two things we need to change in order to achieve these. First of all is the definition of IOP control, and second is the algorithm of glaucoma treatment. Currently, we see the patient every 4 months,
Annalisa,
with
Annalisa.
IOP pressure, and we believe if they're in target or not. The compliance is extremely difficult, and I propose that glaucoma has to be IOP control 24/7 with minimal side effects. And in order to achieve this, we cannot keep treating patients only.
Hey, Annalisa.
We're going to talk about the light study.
Annalisa,
Laser should
she
be
cannot
first
hear
line
me.
treatment.
Annalisa, can you hear me? No, we can hear you, but
Yes.
we are not able to see your PowerPoint presentation. You have to share it.
Okay, hold on.
You have to share it.
I put it to share, so let me see. I am supposed to be in share screen. Can you see it now?
Now we see your screen. Okay, open your presentation.
Okay, here we go again. So as I was saying, IOP, can you
Wait,
see it now?
wait, Annalisa, let's see your presentation.
Can you see it?
No, open the.
I can see it here.
All we see is a whole bunch of presentations. We see your screen, but not the actual. Click on the presentation now.
It's supposed to be there. Can you see it here at least?
We see a whole bunch of presentations. The top one says Ayala updates on canaloplasty Tampa June 2023.
It shouldn't be this. It should be.
You're sharing the folder instead of the PowerPoint.
No. I'm sharing the PowerPoint, but it's not picking up the PowerPoint. For some reason. I am seeing it in my screen.
Excuse me, madam, can you stop sharing and again restart the presentation in slideshow mode?
Yeah, do it one more time. Stop sharing.
Open the presentation and then start sharing again.
Annalisa, did you hear it? Close it, open it, and then hit the share button.
I have it. Have it open. I'm ready.
Excuse me, ma'am. Sorry.
You can let Dr. Devan go, and then I will have it ready again. I may need to shut down and restart.
Yeah,
Hang on 1 second, Annalisa. 1 second.
madam. Ma'am, can you make us the host? Click on
Annalisa, make us the host.
click on our screen by the side and make us the host, please. Yeah. The options on our screen. No, she isn't doing that.
Okay, I'm logging out and I'll log back in.
What did she do?
She has ended the meeting. She was the host, sir. She has ended the Zoom meeting.
I thought you.
We'll start again.
You started?
Yeah, started, sir.
They
Okay,
let's get back to Uday.
No, they're joining now. They're joining back.
Yeah, already. Uday, can you hear me?
You're fine.
Already. So Annalisa will get Uday to give his talk, and then we'll get back to you. Is that okay with you, Annalisa?
Okay, I'm here.
Okay, already. As somebody.
You see my screen?
Yeah, we can see your screen, Uday. As somebody mentioned already, Uday needs no introduction. So I'm not going to introduce you any more than this, Uday.
Perfect.
Yeah, go for
Let's
it.
start.
Go for it.
All right, so you always know that sound. That means cataractcoach.com. So let me show you interesting white cataract cases. At Anand Eye Institute, you see this all the time. You have a case like that. Look how pressurized that capsular bag is. You see how the intralenticular pressure is so high. So we put viscoelastic, and right, what is our teaching? High pressure in the AC, higher than the bag, and let's go in and needle decompress. Here comes the needle, and oh, there you go. Big problem, Argentinian flag sign. Now, there are ways to avoid this. Here's another different method. You can buzz in with the phaco probe and immediately make a hole and decompress the bag. Just a light burst of energy, not a lot. Now, at the same time, notice how the probe staying in the eye for infusion pressure, keep the pressure of the AC high, while through the side port, we're going to use a cystotome and get that rhexis done. Now, it doesn't have to be a pretty rhexis. We're going to do a double rhexis technique, meaning first we'll do a small rhexis, any size, any shape, as long as it's continuous and curvilinear, so that we can decompress the capsular bag here. So there it is, almost done, and just finish it perfect. Now, this ugly little bean-shaped rhexis is fine, because what we can do now is just take out all this liquefied lens cortex, and you can see in this young person, that's a pretty soft lens. So now bimanual IA can be done to clean up the cortex. And again, not a lot of cortex because, again, white cataract intumescent, it was liquefied already. Now you're thinking, well, you don't want to leave a patient with such an ugly-looking capsular rhexis, and I agree, you don't have to. So the double rhexis technique means you're going to do two rhexi. One at the beginning, you may want to even make it larger to remove a dense nucleus, but in a soft lens like this, you can do a second rhexis after the IOL is already in the bag. Now you have a great guide to how to create a good rhexis or capsular opening. And here we go. Now we can expand that rhexis to a much more reasonable or normal size. So a lot of techniques here. You have to know how to manage white cataracts. Remember, white cataracts are the true miracle of modern medicine. You get a patient who's completely blind, and in 5-10 minutes, they can go home with great vision. Amazing. Here's another one. Now let me show you. If you don't decompress it, and here's a case where I'm operating, and we're not going to decompress it, it becomes very difficult. So as I start the rhexis, I'll move quickly. Even then, it wants to run out. So look, I'll have to use this reverse method and pull backwards to rescue the rhexis there. And as I go around again, it still wants to run out, so we've got to rescue it again. So this is why we want to do that double rhexis technique. So you can see there's all the liquefied lens cortex coming out. This nucleus has a reasonable amount of density. We can just chop it up. I don't have to teach you how to do phaco chop. You already know that. You've been watching the Cataract Coach videos. So the nucleus comes out, cleaned up nicely, and finally, there is some light shining on that macula. Here's another case. Now we can decompress with the resident case, beautiful, and go in, and so we've decompressed the capsular bag. You want to make sure the intralenticular pressure is lower than the pressure in the AC. And so if you have a very intumescent or fluid-filled and pressurized capsule, it becomes very challenging. So here, after the needle decompression, notice the resident can get a nice rhexis done.
You also must remember to rock that nucleus back and forth. So here's a needle decompression, going in, aspirate, aspirate. You can see some of the fluid came out, but now rocking that nucleus back and forth. Why? Well, you got to think about it. Where is that liquefied lens cortex? It's not just in front of the nucleus. It's surrounding the nucleus all over, front, sides, back, everywhere. So to decompress it, here's what we have, liquefied cortex all around. We make a puncture site and we aspirate, but then the nucleus moves up and there's still more liquefied cortex trapped behind. So you want to rock that nucleus back and forth to release all of it, and now you've decompressed and depressurized the capsular bag. At this point, this resident can complete a very nice case. So now when it's decompressed and depressurized, look how easy it is to make the rexes. No effort at all. And if you're wondering how in the video the blue dye stains so well, it's because we're doing a longer amount of staining. So here's another device. You don't have to have a fancy device, but here's another one. You can use a Zepno device, which uses a pulse of electric energy in a fraction of a millisecond to go ahead and make a round capsular opening. And you can see that works great, even in this young person with a very intumescent and pressurized capsular bag. So there's the central capsular tissue that was removed, and you can see it's perfectly round, 5.2 millimeters in diameter, and then we'll just fast forward end of the case, there's the opening. Again, fancy toy, but you can simply do this with a bent needle. What about a wrinkled fibrotic capsule like this one? You go inside there and you see, gosh, it's so wrinkled and fibrotic, you may have to cut the capsule. You can use some small scissors. You can even just use a cystotome to nick the capsule there. Now, I understand the capsule rexus is not perfect, but with an anterior capsule like that that's so fibrotic and wrinkled, it's never going to be. That's okay. We can still finish the case here. Here's another one. You say, well, let's use a fancy $500,000 femtosecond laser. Listen, it's no magic trick. It's not any better. You go inside here. This is a femtosecond laser for doing an anterior capsulotomy or capsular rexus. And look, it's still attached. We grab it, there's a couple points of attachment there and there. So again, it works, but it's nothing magical. So again, my take-home message for you is this, the double rexus technique. Notice there's no main incision, just a side port, go inside there, get the small baby rexus done, more viscoelastic if you need it. Once you have the initial small rexus done, you can rock that nucleus back and forth, release that intumescent lens fluid, and the rest of the game is easy. Once you master the capsular rexus in a white cataract, the rest of the cases should be relatively routine here. Now, I know you can certainly do these cases with MSICS, and I love MSICS. Even in Beverly Hills, I do it at least a couple times a year. But in a case like this, you can really do a beautiful phaco as well. And part of the reason you're there at a 9-9 Institute is because you want to learn these modern-day cutting-edge techniques, as well as the lower-cost mass population techniques. You want to learn it all. So there you go. Rexus has been completed now by the resident, and the case can be finished. Here's another one with extensive lens milk. Look at all that liquefied lens cortex again and again and again, and just shows the point you may have to keep injecting more viscoelastic. It's okay. You know how I taught you, viscoelastic is cheaper than vitreous. So use the viscoelastic, and then get this rexus done. Make sure you can see it sufficiently, and that's also why we leave the triped blue dye on the eye, on the anterior capsule, for at least 15-20 seconds. Here's a case at the end. Resident doing a great job. These are beautiful cases to learn phaco chop, because here you can see the double angle here on the side. Resident does a very good job. You've got a blue dye staying in the capsule, so you see the rexus edge. You can see this nucleus as it comes up. This is a typical white cataract where it does have some nuclear density, but chops relatively easily. And remember to differentiate this from the purely intumescent, soft white cataract that you can remove with the eye probe, or the brunescent one that has that yellow and brownish color as well. And then finally here at the end, this is me doing a white cataract case. We still get these even in the fanciest parts of town. This is a relatively common thing. I do at least a white cataract a week. And you can see just chop, chop, more chop is my favorite technique here. And we can aspirate this out pretty easily. So I hope you enjoyed these cases. And thank you, Ramesh, for the opportunity to participate in your course.
Oh, very slow. So Dave, thank you. Awesome. As usual, great job, and you continue to inspire all of ophthalmology throughout the world.
And then I hope next year for our video contest we have many more entries from the surgeons at Anand Institute.
So next year, yes, we just had this video conference, the cataract coach and USF competition. Next year, I expect a lot of competition. Now, here's the deal, right? I want that to be a purely a resident or a fellow case. I don't want attendings to do the case and submit this. That's what, and so we are insisting, we are, as me and Uday watch these cases, we are making a judgment call. Is this a resident case or is it a attending case that the residents are presenting as theirs? So we want to make sure that the residents are getting what they signed up for. And they're actually learning, mastering the technique, and in so doing, create a video out of it and send it to the competition. So thank you, Uday, for reminding us.
Thank you.
Thank you. Bye. Annalisa, you're on. We can see your video. We can see it now.
That's good. Now we're good. So as I was telling you, we need to change the way we are treating glaucoma, and just one IOP pressure every 4 months is not enough. In order to do this, we need to actually change the way we treat glaucoma, and it should be laser, mix, and appropriate incisional surgery with drops in between these treatments that can give you 24/7 control. We need to change our mindset. I'm not sure how accessible is SLT in India, but even in the US, we've had SLT for years, and a lot of doctors are not using it as first line. 73% of the patients in the LIGHT study were at their target pressure only with laser, and they required less surgery with a better quality of life. Also, there was another study with the stent, the hydro stent, then even though the pressure was only 1 millimeter of mercury between the treated stented group or the phaco group, there was a third of increase in needing of incisional surgery on these patients that did not have 24/7 control. So why do we need to get an alternative to medications? Well, multiple drops leads to poor compliance, surface, blurry vision, for a disease that patients don't feel. We know that BAK is toxic even to the trabecular meshwork, causing apoptosis and inhibition of oxygen consumption in the mitochondria. And even if the patient is trying, just getting a drop in, this patient has gone to 2, here goes one more, 3, 4, she got it on the 4th or 5th drop, and in the other eye, she goes to 3 more. That's 7 drops. So at the end of the month, even if she's trying to be good, she's going to be running out and having more calls. So she might not be getting the medication throughout the year. So what can we do with canaloplasty? If we take this, we know that the trabecular meshwork and the Schlemm's canal gets stiff. There's a deposition in the basement membrane that makes it less pliable. And by just dilating it, we cause microfractures in TN, we break the obstructions into the collector channels that can happen as the pressure goes up. We can see here an electron microscope. You can see actually the collector channels here, and they can get obstructed by DTM when the pressures go up. And with canaloplasty, we can actually avoid this. It keeps integrity of the trabecular meshwork, 360 dilation, low complication, implant-free, and you can repeat it. In the US, we have multiple systems. You can always do GAD, but make sure that you inflate with viscoelastic. There's a cannula you can buy, it's like $200, that can help you, has a good angle in order for you to pass viscoelastic into the system. The iTrack system in the US shows a decrease in medications from 2.1 to 0.6 at 3 years, with a drop of up to 5 points in IOP at 3 years. And there's another device, the Omni here, that can actually achieve similar results. Why is this important? Well, this is an intraoperative OCT that we're going to be able to see. I want you to pay attention here, where you are going to be able to see the collector channels. This is a nice collector channel here. And you can see the little light from the iTrack system. And you're going to see how the Schlemm's canal goes from oval to round as it gets pressurized with viscoelastic, allowing you to not only cause these microfractures, but if you will do a GAD or a goniotomy after, you're going to get smaller leaflets that have less chance of obstructing your collector channels. This is the eye tract system now from the outside. You enter the eye with a cannula and you pass this microcatheter that has a little light. It actually shows you where in the canal you are located. You can see the little light down here. As it advances in the Schlemm's canal, and once you go 360, you're going to pressurize viscoelastic up to 100 microliters of viscoelastic as you pull out on the canal, and you can see how the collector channels and the episcleral veins get full of viscoelastic. This is the amount of viscoelastic in 30 clicks of the device. So you can only imagine how much viscoelastic you're using to pressure clean the system. There are other devices, as I mentioned, in the US. This is called the Streamline, and it basically has a microgoniotomy that comes as the sleeve retracts. You align the blue sleeve, which the canal, I want you to pay attention in this area now. As you're gonna see as I do the second one, the blood in the Schlemm's canal gets moved. Here it comes again, and you see reflux into the anterior chamber. You create microgoniotomies of 150 microns, and you can actually connect them after you've pressurized your system. The amount of viscoelastic that you will get is considerable. I want you to see here the amount of viscoelastic we're gonna be getting. And here it goes. This is the amount of viscoelastic you get per click. You can do up to 8 clicks with this device. And it's 7 microliters of viscoelastic per click. And last but not least, this is the canaloplasty.
Annalisa, can you hear us?
కరెక్టే ఉంది సార్ జాయిన్ అవ్వలేదు. హలో 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 హలో
Annalisa, can you hear us? Text me if you hear us. Is the Zoom connection still on? I know Venkatesh ni room lo undamani cheppamanadi. I told that guy should not leave. AV person should be there 24/7 during the conference. Anyway, I think it may be her system. I don't know.
It is.
Why don't you log out and log back in?
It just. మన దగ్గర కనెక్ట్ చేసి చూసుకోండి. మీరు కనెక్ట్ చేశారు సార్.
Can you hear me? Satish? On your...
Hello. Hello. మీరు ఇక్కడ ఏమైనా చెక్ చేసేసారా?
ఈ settings ఏమైనా change చేశారా? It says you joined there.
Hello. No, audio is at previously just remove the audio jack now. In speaker computer speaker.
Computer speaker board again. It's up.
Anglisa, you are able to hear us? She is not there. Anglisa, you are able to hear us? It's working. It's working.
Okay, let's move on. Let's move on.
Now it is working.
Yeah, I know. So log off. So there's no resound. You want me to finish my thing, or what do you want me to do?
We will have our presentation, sir.
Yeah.
In Malaysia,
Okay.
we'll start.
Thank you, Annalisa.
She's not there, sir.
Yeah.
ఇది ఎలా అనిపిస్తుంది ఇది ఒత్తికొట్టి అయిపోయింది మన స్పీకర్ యా హూ ఇస్ ద నెక్స్ట్
ఇది మాట్లాడుతుంది
So now we move on to the consultant presentations. So we have Dr. Divya, who is the oculoplasty surgeon here.
Two are there. This one. Your PPT, no? This one. Minimize it.
Good evening to everyone. Today I am presenting a case of sequestration ectropia. A 25-year-old came to the OPD with a complaint of not able to close his right eye, upper eyelid since 2 months, followed by a road traffic accident 3 months back. On clinical examination, there is a scar on the right upper eyelid, which is extended from the eyebrow to the lid crease, not involving the eyelid margin, causing a lag of ophthalmos and closure of the eye. The diagnosis is a sequestration ectropion. We explained the procedure to the patient and planned a full thickness skin graft under local anesthesia. The steps of the surgery: step 1, release of scar tissue till eyelid margin becomes normal. Step 2, harvesting the full thickness skin graft from the post-auricular area. Step 3, suture the graft into position. So the skin incision was made and release of scar tissue from below and above till eyelid margin becomes normal. So once the eyelid margin becomes normal, we have to measure the defect. With the same measurement, the graft was taken from the post-auricular area. The wound is closed with the 4-0 silk. Once the graft was removed, we removed the subcuticular from the graft, and the graft was placed over the defect and sutured with the 6-O-Prolene and 6-O-Vicryl. Pressure bandage was given for 5 days. Post of 5 days, the graft was well opposed with no evidence of lag of ophthalmos, and the lid margin was normal in position. After post of 1 month, on opening the eye, the eyelid position is normal in position with minimal scar, and there is no evidence of lag of ophthalmos even after post of 1 month. These are pre-operative pictures before and after. We have a similar case of sequestration ectropion in the lower eyelid. We have taken full thickness skin graft. This is the post of 5 days, and this is after 1 month. If you see, the lid margin is normal in position with no evidence of lag of ophthalmos. There is minimal depigmentation of the skin graft. These are pre and post-op pictures. To conclude, the full thickness post-auricular skin graft in sequestration ectropion not only gives a good cosmesis outcome, but also helps in relief of symptoms caused by lag of ophthalmos. Thank you.
So that was an interesting case. Dr. Ayatri, do you want to ask any questions, or should we proceed to the next one?
I'm no expert in plastics, so it's stupid for me to ask any questions. But do you get a lot of
a severe injury, if they have a skin loss, then they heal with a sequestration ectropion. So where you need a skin graft only.
Very nice results.
Thank you, sir.
So next we have Dr. Anupama, who is the cornea consultant here.
Good evening, one and all. I would like to present an interesting case. Management of secondary lipid keratopathy by deep anterior lamellar keratoplasty. So this is a 33-year-old male with history of alkali injury 10 years ago. You can see the right eye, counting fingers 1 meter. You can see an advanced secondary lipid keratopathy in the center, long-standing deep vascularization, well-defined efferent and afferent feeder vessel complexes also seen. The B scan and pressures were normal. So here is the preoperative picture. The markings that you are seeing there are burns given by argon laser photocoagulation that we had done prior to the surgery with the help from our retina colleagues to minimize the future lipid depositions after the graft. Here downside left you can see the pre-op ASOCT anti-segment OCT picture, thin scarred irregular cornea but good epithelialization. So these are the intraoperative pictures. The challenges that we faced were of poor visualization, and also we had to do a meticulous layer by layer dissection owing to the irregular stroma and also bleeding from the deep vessels. But we could successfully finish the procedure as shown with the picture at the last. So day 1 post-op, there was a double anterior chamber noted because the posterior complex was not that good adherent to the donor cornea. But since there was no perforation, we just waited, and by day 7 it got reattached, the DAC was closed, and the best corrected visual acuity went up to 6/18 unaided. Here I show you the pre-op and post-operative pictures. We could achieve a reasonably clear cornea by the end of 1 year with struggle with the steroids and 4 sittings of argon laser photocoagulation intermittently. But as you can see here, the patient is still doing well with 6/18 unaided. The central patch of lipids predesmatic area was deliberately left behind because of thinning there and its proximity to the desmids. So the epithelialization is still maintained. So what else did we do in this case? Apart from argon laser photocoagulation, we also did a needle thermal cautery intraoperatively to the corneal vessels to curtail the interface lipid deposition and possibly limiting the future interface haze that we could achieve in a 1-year follow-up as well. We did not employ any VEGFs here because the maintenance of chronic neovascularization appears to be less dependent on VEGFs. So as you can see, lipid has been deposited in our case because of alkali burns which caused severe inflammation that promoted neovascularization due to hypoxia and also mechanical injury. Secondary lipid keratopathy typically presents unilaterally with cream colored opacification adjacent to neovascularization. So what was different here? Why did we choose a DALK while the classic teaching is do a penetrating keratoplasty in advanced lipid keratopathy? We choose this to preserve the structural and immunologic integrity of the globe considering the patient's age, that is 33 years, and phakic status, and we took its demerits of suboptimal visual outcomes as well. But we could achieve a reasonably clear cornea with good vision and good surface epithelialization post-operatively through all our struggle, though a longer follow-up is required to comment on the recurrence of lipid. We also published this earlier this year in Indian Journal of Ophthalmology. Thank you.
This is great. I thought this laser to those blood vessels does not work, but obviously.
No, it does work, sir. It works only for certain amount of only to like, it gives you a time for around about 6 weeks to 12 weeks. Again, it is going to come back again, so we need to keep looking into it. That's what it is.
Yeah,
But,
I mean, this is interesting.
but what was very important here is that she tried a DALC in this.
Yes, doing the DALC for lipid keratopathy.
And now 18 months post-op, sir, patient is
He's
still
doing well.
doing
Yes.
618 parts and he's maintaining.
I mean, conceivably, if the patient develops lipid keratopathy all over again, you can repeat this DALC procedure.
Yes, sir. Yes, sir. After this patient, we did it in a bilateral lipid Cogan syndrome patient who had systemic dyslipidemia also. This patient did not have anything, but that was a bilateral viral, young 20-year-old who had already hard of hearing. So seeing was his only way of communicating. So there we repeated, after 3 years, we repeated one eye. He is holding 6/9 both eyes now. No glaucoma, clear lens. He's doing well.
That's the other beauty of DALC, right? I mean, no glaucoma.
Yes, sir.
Unless they have, primary open glaucoma going on, but if you surgically induce glaucoma is not there. Wonderful. Next time I come, post a DALC, I want to watch you do your DALC.
Thank you. Thank you, sir.
Thank you.
Thank you.
Now we have the glaucoma department presenting there, please.
Good evening, everyone. I am Dr. Pasyanti, consultant in glaucoma and cataract services here at Anand Institute. So here,
Glaucoma, you're taking the contest?
so today I am presenting an interesting case which I have titled A Ticking Time Bomb. So a 56-year-old female had come to us with diminished vision in both the eyes since 2 years. So she underwent cataract with trabeculectomy elsewhere 3 years ago, and then 6 months post-operatively she started developing decreased vision in that eye. The other eye also had decreased vision. When she had come to us, she was on anti-glaucoma medication in the right eye, and she was on nepophenac eye drops in the left eye, the eye which has underwent cataract with trabeculectomy. So the right eye visual acuity was 618 parts, and IOP was 18 millimeters of mercury with anti-glaucoma medication, and she has a significant cataract. In the left eye, the vision was 624 parts, and you can, if you can see, there is a thin cystic avascular bleb, and there was no frank leak on serals, but there was bleb sweating. Whenever the patient was blinking, we could see some watering in the eye, and she also gave history of watering when she got up in the morning, but there was no frank leak. The AC was shallow. There was a patent PI. The surgical PI of cataract with trabeculectomy that was done was also there. And the IOP was 4 millimeters of mercury. She had significant angle closure in both the eyes. And the right eye fundus showed a 0.6 cup with the healthy neuroretinal rim. And the left eye had an inferior excavation with a 0.8 cup. And what is most noticeable is the ILM folds that you can see at the macula. Not sure if that is visible.
Only retina specialists can see.
So she had hypotony maculopathy in the left eye because of the low intraocular pressures, because of the sweating blood. But we wanted to rehabilitate the patient because she had significant cataract in the right eye. So we did the cataract surgery in the right eye, post which her vision was good. And in the meantime, we had put her on gentamicin eye drops, which is an irritant, and it can stimulate fibrosis in that area and probably can help her in decreasing the watering in that eye. But finally, there was no improvement. She still complained of watering, so we planned a bleb repair with conjunctival autograft as the area of avascularity and was more. So this is these are the intraoperative pictures. So the area of the avascular bleb was measured both horizontally and vertically. And then conjunctival autograft was taken from inferior conjunctiva along with the tenons. And the area of the cystic bleb here was excised, and there was no scleral defect that was seen. The rest of the conjunctiva was undermined, and then the conjunctival autograft was placed over the area of the excised cystic bleb, and then it was sutured with 25 sutures with mattress sutures anteriorly. Postoperatively, day one, the IOP did not improve much, but the anterior chamber was deep, and she still had the ileum folds at the macula. This is the postoperative 1 month picture. The graft was well taken, and the anterior chamber was deep. The IOP improved to 16 millimeters of mercury, which was such a relief to us. But of course, the hypotony maculopathy persisted. And this is 8 months postoperative picture, which shows that the bleb is well taken and the bleb is well formed. The IOP was 16 millimeters of mercury, and she had a vision of 612. These are the ileum folds at the macula. And this is 5 years post-operative. This patient has visited us last 2 weeks back, and this is the area of the bleb. And there was no leak, and she had an intraocular pressure of 14 millimeters of mercury with a vision of 6.9. And of course, she still had the fixed folds at macula. The hypotony is not there, but she still had the fixed folds at macula. So these are the folds at the macula. And this is the OCT picture showing the ileum folds. So what is a late leaking bleb? Bleb leak that occurs after 3 months of surgery without an obvious trauma is a late leaking bleb. And what are the predisposing factors? If you have a full thickness procedures which are not done now, but which were previously done, or if you use an antimetabolite adjunctively, and any thin cystic bleb has more chances of bleb leak compared to thick walled blebs. And these bleb leaks can be 2 types. They can be either high flow leaks, which are Seidels positive, or they can be low flow leaks with transconjunctival ooze. What if these are left untreated? We can have persistent CD, shallow anterior chamber, which can cause cataract, peripheral anterior synechiae, hypotony maculopathy, as in our case. And the ticking time bomb is the blebitis and the bleb-related endophthalmitis. These patients are more prone to develop these infections, which are dangerous to the eye. So when do we have to wait and when do we have to treat? So we wait if we do not have any complications and we have formed blebs with normal IOP, good central vision, and no history of bleb-related infections. But we treat when we have one-eyed patients, when we have ocular hypotony and shallow anterior chamber, decreased vision, and any previous bleb-related infections. So how do we manage? There are various methods. Conservative management includes using aqueous suppressants, pressure patching, symblepharon ring, large diameter contact lens, tissue glue, laser. So various methods have been tried to help these bleb not leak. And then if all these fail, then of course we have the surgical management where we can do a rotational flap, and if the area of defect is left, we can just advance the conjunctiva, or we can do a free conjunctival autograft, or amniotic membrane transplantation can also be tried. So the take clinic message would be bleb leaks have to be identified early and repair has to be done to prevent permanent sequelae, like in our case, and sight-threatening complications. Various management options can be considered based on the extent of the leak and the causative factor. So I want to share one of the videos also. This is the case, this is another case where AGV was done in a patient with post-vitreoretinal surgery. So she had a fibrous conjunctiva. So this is a video showing when I was, so I generally start the incision 3 to 4 mm behind the limbus. So once I started, I could see there was thinning in the area anteriorly near the limbus. And once I placed the patch graft, I could see a nice buttonhole there. So what was done, I undermined the conjunctiva behind and sutured it anteriorly, like the trabeculectomy. So I sutured it anteriorly with the wing sutures and a mattress suture. Okay. Close this. So this was the buttonhole that was seen post patch graft. So the conjunctiva was undermined and again sutured anteriorly with wing sutures and a mattress suture To be on a safer side, I also did a 10-0 nylon suture to the tying it to the cornea. So the take-home point from this case is preserving the conjunctiva is most important, because all these patients with vitreoretinal surgery or corneal surgery definitely would need a glaucoma surgery at a later point of time. So preserving the conjunctiva is definitely must. Thank you. I also have a post-operative picture of that. Is there any?
Very nice. So I don't believe in all those medical treatments. When there is a leak, there is a leak. All those things they got into the literature by glaucoma specialists traditionally have been poor surgeons. Okay, they're not trained surgeons in the past. So they came up with all these non-medical ways of treating. A leaking bleb is a surgical disease process in my mind. I see a leak today. Within the week, it's done. I mean, I take them back to the operating room. I use a different technique where a lot of people believe in taking down the leak, the cystic bleb, right? So when you take down the cystic bleb and either close the bleb with advancing the conjunctiva to cover the bleb, that area of the trap site, or by doing this conjunctival transplant, 50% of the times the bleb will fail because of fibrosis now. So now you replace the low pressure with a super high pressure, the entire area is scarred down, now you're going to scratch your head. So about 15, 20 years ago, I published this in the glaucoma journal Glaucoma, where what I do is drape it with amniotic membrane. So you scrape off the epithelium from the cystic bleb, drape the entire thing with the amniotic membrane. Now you put the conjunctiva on top of that. Now, if the bleb is too large, what I do is you can apply cautery in rows, so the size of the bleb shrinks. Then you put the amniotic membrane graft on top of that, suture it on either end of it, and then pull the conjunctiva, pull the conjunctiva or take your conjunctival graft like you did, and then place it on top of that. Almost 90% of the times, you will end up with pressures between 10 and 15, and these patients will continue to do very well. That's been my experience. So that's my preferred method of taking care of these patients. A leaking bleb is a ticking time bomb, like you said. I don't want to try out all those methods which they don't work, first of all. If it is going to work, it's because even if you have not done anything, it would have worked. Okay, so, and two, in terms of the hypotony maculopathy, it depends upon the time, how long that hypotony has been there and those retinal folds have been there. If it's more than 6 months, in my experience, those folds will stay. If it's more than 1 year, they definitely will not unfold unless we have a master surgeon go in and unfold them probably. And what I do for hypotony maculopathy is to titrate the pressure on the table to greater than 20. I leave it between 20 and 25. And I will wait for the hypotony to completely resolve before I let the releasing suture or cut one of the sutures down to a reasonable level for the glaucoma situation. That leads to faster resolution. I get, every 3 months, I get a referral with hypotony maculopathy. So I've taken care of a number of patients over the last 20 years. And the worst case situation is if they have been there for more than 1 year, I just could not, even though I do the glaucoma portion of it, I don't see significant vision improvement. But very well, very nicely done. Thank you.
Now we have our director, Dr. Satish Agraharam, sharing his interesting case.
Thank you, Pasanti. I think one point I just wanted to mention about the hypotonic maculopathy. I mean, the persistent of internal limiting membrane folds. Whenever there are internal limiting membrane folds which are persisting for more than 6 months, then usually they tend to remain fixed. The reason why they tend to remain fixed is the internal limiting membrane undergoes a little amount of fibrotic changes. This is what we actually see when we operate patients with traction retinal detachments. Long-standing traction retinal detachments which have got ILM folds on the macula, Even you relieve the traction, you put in a gas tamponade, you wait for 6 months or 1 year, you'll still see some amount of fine amount of folds. And these folds only unfold, that underlying retina tends to unfold a little bit gradually over a period of years, only if you peel the internal limiting membrane in that particular area. Otherwise, these retinal folds tend to remain with you like that. See, by correcting your intraocular pressure, you're actually correcting your pressure. So the hypotonic maculopathy component is gone, but the folds will still remain. You can't call it anymore as a hypotonic maculopathy at that particular point of time. Okay, so I wanted to share the other day, even in the, Dr. Ayala was talking about infections, and especially these infections, the worst infection somebody can get is a fungal infection. Now, the biggest problem with fungal infections is we do not have fungicidals with us, and fungus needs a good amount of debulking. I mean, if it's a corneal, let's say there is a corneal fungal infection, all you need to do is take the corneal button out, and then you debulk the entire fungus out, and you put a therapeutic graft, and then later you want to put an optical graft, and you have a say. Unfortunately, you can't do that when you have an infection inside the eye, that is the fungal endophthalmitis. This was one of challenging cases because the patient was extremely demanding for us to go ahead and interfere multiple times, and we have a interesting concept of treating the fungal endophthalmitis. He was a 74-year-old male who had presented to us with a diminution of vision in his right eye. He underwent a cataract surgery 10 days back, and the first post-operative day, he landed up in an infection. That was an endophthalmitis was detected. And I think the second day they took, the treating retinal surgeon did a vitrectomy with intraocular antibiotic injection, and he sent the sample, and the sample showed a fungal infection, and the patient was put on some antifungal agents. And after 10th day, because the pain and the redness and everything was not coming down, the patient came to us for an opinion to do any further intervention was possible or not. And he was a known diabetic and hypertensive for 20 years, and the only thing the patient was telling us was he was seeing well prior to the surgery, prior to the cataract surgery. When we got back and checked his reports, he had 6/9 vision with the best corrected visual acuity in that eye prior to the surgery, and now he has come to us with PL positive and PR inaccurate kind of a picture. These are the anterior segment findings, otherwise absolutely normal. This was the anterior segment picture which you can see, and the comparison with the other eye. So practically you can see actually the entire fungal infection has gone onto the cornea. There's a massive hypopyon, there is a chemosis. In fact, this is actually an endophthalmitis which is actually leading into a panophthalmitis. That was the kind of presentation what we had. So we discussed, and we already know the etiology, it is fungal, and we discussed the option of evisceration to the patient. He said, if we cannot hold it for longer time, then possibility that you may have to eviscerate the eye. But the patient was very keen on interventions, and I said, okay, let's give it a try. And so our concept is and this is the B-scan picture. You can actually, if you see the B-scan here, you can actually, the choroid is actually grossly thickened. And inferiorly, you can see a small area of retina which is getting detached, and entire vitreous cavity is still filled with fungal elements. You can actually see so much of condensations which you see. The difference between what you see in a bacterial endophthalmitis and fungal endophthalmitis, bacterial endophthalmitis tend to liquefy the vitreous. So you will see a liquefied vitreous in a bacterial endophthalmitis, whereas in a fungal endophthalmitis, the vitreous tends to get condensed. So then that's the biggest problem. When it tends to get condensed, it tends to stick onto the retina more, and then it tends to produce traction. And majority of your fungal endophthalmitis, either they pull down the ciliary body producing a persistent hypotony, or they pull down the retina and causing a very bad retinal detachments. That's the problem with the fungal endophthalmitis. So at this particular point of time, we have a treatment plan where what we believe is fungus is very difficult to treat with one injection of amphotericin B and one injection of voriconazole. If you look at the half-life of amphotericin B, it's got around about 48 hours. It works for 48 hours. If you look at a half-life of voriconazole, what we inject, it works for only 6 to 8 hours. So voriconazole works better. Voriconazole works better for these kind of patients. And so what we do is every after 48 hours, we repeat the injection, intravitreal injections. Now the idea of giving these repeated injections is to get the load of fungus down inside that particular eye. And this is what happens. So day 1 at the 9th we gave 1 injection, day 11, on the 11th we gave a second injection, on 13th we gave the third injection. And by the time we were giving on the 16th of that particular month, you can actually see the cornea was not responding well. The cornea was not responding well. So we did a therapeutic graft. And we explanted the IOL also at that particular point of time. But we continue to give injections every second day for this particular patient. Now the biggest problem with amphotericin B is if amphotericin B gets in contact with the iris, it tends to produce neovascularization. So that's why this patient was developing a recurrent eye FEMA. So on 18th again they did a wash because the eye FEMA was full in that particular eye. AC wash was done and a release of Sinicate was done for that particular patient. And then we continued the injections. And later we realized that at this particular point of time you can actually see when you repeat, we have been doing a serial B scans for this patient. Look at this point of time. At this particular point of time you see the vitreous cavity has cleared a bit. The amount of debris inside the eye has come down, and you can actually see that this particular portion you can actually see the retina is getting detached. I know there is a retinal detachment there, but now what you can see, there are areas of clearing in the vitreous cavity, So now I just wanted to show you the picture pre and post. Post almost 9 or 10 injections, you can see pre-injection and post-injections, and except for there is a component of retinal detachment. Now at this point we took up the patient for a vitrectomy and with a silicone oil injection, and we also added again 1 more dose of voriconazole and amphotericin B for the patient at the end of it. And this was the picture 12 days post-operatively. From an eye what looked like, and now you can see an eye which has become quietened down. Vision was hand movement, the best corrected visually was hand movement at 12 days post-operative, and you can actually see vaguely the fundus. You can actually see vaguely the retina, you can see the gross sclerosed vessels, you can appreciate the disc, and this is what is going to happen because the fungus has stayed inside the eye almost for 25-30 days, and the toxicity of the retina has caused all these vascular changes inside the retina. Now by the end of 45 days, this patient had a quiet eye. You can see the comparison, the day 1 when he presented to us, the day at the time of where he underwent a therapeutic graft, and the day post vitrectomy 45 days, you can actually see the eye has become actually quiet and the patient has around about 2 meters vision. Now this patient we followed up for almost 6 months, and at the 6-month visit his patient best corrected visual acuity became 6/36. Eye was quiet. Unfortunately, the 2 days after our follow-up, the patient had a massive MI because of his diabetes and hypertension. He could not come back. I was actually planning for an oil removal, and he was asking for an IOL. I said, you have removed my IOL, I want my IOL back. Then I said, okay, let's plan it after probably 1 or 2 months, and unfortunately we lost the patient because of other things. But the take-home message is like this. Endophthalmitis, acute endophthalmitis, even you can get in a fungal infection too. So don't keep fungal infection away. Acute endophthalmitis presentation can also occur with fungus. A simple vitrectomy, just doing an intraocular antibiotic injection, single injection may not be sufficient for fungal infections. You need, you need repeat intravitreal antifungal injections, which is one of the key to control massive fungal infections. Of course, majority of the fungal infections, either they do land up in an hypotony or with retinal detachment. So we need to probably wait till we can get a clear view, do a good vitrectomy, and a silicone oil tamponade is what is needed. What is very important in all these processes, we need to put the patient on oral antifungal agents up to almost 12 weeks for these patients. That is something which we need to. And one last thing, do not forget to follow up this patient for the first 2 years. The maximum amount of recurrences do occur in the first 2 years. And after 2 years, if the recurrences do not occur, the possibility that the fungus is going to recur is on the lower side. Thank you for your patient hearing. Anybody has any comments?
What was the fungus? Candida or Fusarium?
This was aspergillus, sir.
This was aspergillus.
No wonder it responded so well to our voriconazole. Our voriconazole response was good. And so voriconazole I can't poke into his eye every day. So we choose alternate day because amphotericin also has got a good effect on this
So I have
aspergillus.
a question. If I give you slow release amphotericin B with one injection, it lasts for about say 72 hours. Is there a role for that?
I would, amphotericin B lasts for 48 hours.
Okay, so if I give you for a week, give you one injection.
I would prefer a voriconazole, but amphotericin B or oniconazole sustained release is going to work brilliantly.
I don't have voriconazole model. I do have natamycin, slow release natamycin,
Okay.
slow release amphotericin B.
Great. I mean, that should do well. That should do really well. See, the concept is there are only very few people in this country who believe in giving multiple injections for fungal. And my thought process is this: fungus can't be killed with one injection of amphotericin B, one injection of with so much of fungus sitting inside. And you could see yourself, and we do have quite a good number of cases where we have done multiple injections into these patients. I would say 6 or 7 out of 10 fungal infections we could salvage.
Yeah, I do the same thing even for the anterior segment, by the way. Repeat injections of amphotericin B and voriconazole. I do that when the topical natamycin does not work. Like I told you, what I do is to go in with an 18-gauge needle, suck the hypopyon out, and then fill the chamber with amphotericin B and voriconazole. I do that repeatedly every 2 days. It's painful, but that's what really stops the infection in its track. And then I'll come back with an Godison flap, and then 6 months later I go ahead with the therapeutic transplant or whatever is needed. I am a big believer in this kind of repeat injections for fungus.
Yeah, that is the point which we wanted to highlight, that with fungus, you need to be very persistent in making sure that. Now, people often ask me, what is the end point? For me, the end point is when you see the vitreous cavity clearing. You could actually see, if you can go back into the picture, you can actually see the vitreous cavity is clearing. I mean, everybody will agree that the vitreous cavity is clearing. The moment the vitreous cavity persistently for 2 or 3 scans, if it is shown signs of clearing, that is the point where you can go inside. And remember, a lot of people, like I think the All India Institute of Medical Sciences group, they say that as soon as you see fungal endophthalmitis, you have to go inside, induce PVD, do a vitrectomy, do thorough, then put a silicone oil tamponade, and it works wonders. But with a fungus sticking onto the surface of the retina, it is impossible to pull out get a PVD out of these particular patients. And the view is going to be so terrible for us that we will not be able to, and without removing the vitreous, you cannot push in silicone oil in any eye. It is not possible at all for us, practically on the table for us. So by giving these repeated injections, one good thing one of the ways, suppose somebody has got a vitreomacular traction, a very fine attachment on the macula. One of the ways people actually achieve a PVD is by giving an injection into the eye. It could be a simple sham injection of a simple water, distilled water, a sterile water into the eye. The very act of pushing something and a bit of vitreous blob which is coming out, that itself induces a PVD and the traction gets relieved. I mean, we don't inject water, but we inject an anti-VEGF and saying that, at least we have injected some medication which is acceptable, and it actually releases traction. So this is exactly what is going to happen for us when we operate after 7 or 8 injections of intravitreal injections. We will be able to do a good job. We'll be able to do a good job inside. That is what it is. Yeah, it tends to produce revascularization of the iris.
We get to risk in the very big profile here. Are you going to lose the entire eyeball, or am I worried about a few blood vessels coming on the iris? So I mean, one caveat here is this: a lot of young doctors, what they do is they think about all the possible bad things, complications that can happen, and then they hesitate doing the right thing for the patient. What does the patient care if there's a few blood vessels in the eye? I mean, it doesn't matter at all. In the long term, they will disappear. That's in the acute phase he's talking about it. You give amphotericin B, there are some blood vessels that flare up and there may be some hypopyon. You follow those patients, I feel, their blood vessels will go away. So I'm becoming more and more, I see, when I was in SD hospital, they used to have a floor full of, the second floor used to be full of these infections. I went to Madurai, they have an entire floor full of fungal infections. I think fungal corneal infections are they're causing tremendous distress to these patients. And most of them are farming community, they're poor, they come late, and then they're mistreated, they're misdiagnosed initially by the local ophthalmologist. By the time they come to us, it's already a month or 6 weeks later, it's already invaded. I'll show you some, at least one case today. It's a terrible thing. I mean, you put these natamycin drops and verconazole pills for months on end. How long is this patient going to suffer? Some of them actually get depressed to the point they'll say, please take this eyeball out. I can't live this life anymore with these drops.
Sir, we have Dr. Srinivas Prasad, good friend of mine, who was the head of the Department of Cornea from SD Hospital. Now he's on the therapeutic graft day, they also we gave intravitreal injection. At the end of the graft, we pulled out the IOL. At the end of the graft, we gave an intravitreal injection. Then that injection schedule wasn't changed. Every 2 days, you have to get the fungus out. You can't have a gap. You can't have a gap. 3 days, 4 days, you give a gap, again the fungus will start multiplying. Although it multiplies, see, to get a fungal endophthalmitis in 24 hours, how does the fungus has to multiply? Normal thought process for us is that fungus is going to multiply very slowly. It is going to take chronic endophthalmitis, old infection, less of symptoms, more of signs. This has been our standard teaching, but fungus doesn't behave like that. Fungus can become extremely fast growing, extremely invasive also. So when such a kind of a picture, what you are seeing in an acute endophthalmitis patient, that means the fungus is a fast growing fungus. I need to act very quickly for this particular patient. So that's why we don't give a gap for this patient. In fact, you will be surprised, Dr. Prasad, that there are some patients where they develop gross hypotony. Even in a hypotenuse eye, we struggle to give injections, but we manage to give injections for these patients. But we wait for the sign of clearing in our B scans. If the B scan shows sign of clearing, then we go inside and intervene. Without showing signs of clearing, we don't interfere in it. It's not saying that I am getting 100% result, but I am definitely telling you that it is far, far better than leaving it alone. At least 6 out of 7 or 7 out of 10 we are able to salvage. Yeah. It can come forward. It has to come forward. In AFAK, it will definitely come forward. I think my goal here is to treat the endophthalmitis, then I'll look at the cornea. Anyways, it was a therapeutic graft for this patient, which actually held for a long time. That was what it is.
So can I answer this question? Are you worried about keeping the eyeball and having some vision later on and doing a BSAC or a full-thickness cornea transplant? Or are we worrying about stupid things like endothelium? This is exactly the same point that I was trying to make. I'll share some insight into how fast this fungus can grow. I had a patient that was non-responsive to fusarium infection of the cornea, non-responsive to the natamycin drops of verconazole, and I walked into the hospital for some other thing, and she said, I want Dr. Ayala to see me, and then I looked at it, half of the eyeball antechamber was filled with the hypopnea. So I stuck it in an 18-gauge needle to suck it out. Normal, anything smaller than that, it's so thick and gummy that you won't be able to do that, right? And I watched this patient every single day. Within 24 hours, 30% hypopnea was reformed. In fact, I could watch on the endothelial side of the cornea pus or purulent discharge coming out. That's how fast. If you think that hypopnea is just pus, I don't think so. I think it also has fungus in there. That fungus is secreting this material into the antechamber. So every single day, as I was repeating the injection every other day, I would go in and watch this, and that's when I decided, this is several years ago, I just wish I had a video of this. That's when I decided, you know what, this treatment that has been a standard of care across the country and the world actually is no longer the standard of care. These patients need better care. And if I were you, sir, what I would suggest is this: do a therapeutic transplant as soon as you see a fungal infection. That's what I am doing, and my results are extremely good. Patients are happy. You know, patients are happy. The pain is gone. They can see some out of the eye. Yeah, after that, I can use nanomycin and voriconazole. I continue to do that for at least 2 months to prevent the recurrence of it. That's what my current regime is. We're gonna have publications on this soon as to how to do this needle procedure to drain the hemophilia out, etc. But SD Hospital, you guys are full of this thing, right? Is this still the case? That was the case 40 years, 30 years ago when I was there.
Sir, I think you have Dr. Srinath Prasad was he did PG. Both of us did PG together, but he was the head of the department of cornea. He is the one who actually brought some sense into cornea department in SD Hospital. And he was the one who established the entire corneal bank, eye banks, and all that stuff there. You have one question. Hi, Milind, welcome. Please come.
Sir, as I understand, oral antifungals were started along with your voriconazole.
Yes.
There's a risk of systemic toxicity. Was it monitored, sir?
Yes, yes. See, the patients attender were couple of them were doctors, and so we made sure that they had. See, whenever we give oral antifungal agents or any other immunosuppressive agents, we make sure that they have to follow up with their local physicians. That is a must for us.
Systemic toxicity is more with the
Yeah, I do agree with you. Okay.
You know, my wife is IV infectious disease specialist, so my consultations are in the house on a dinner table. For oral voriconazole, I have never sent a patient for renal checkups and stuff like that. You have to see, yes, theoretically speaking, there is toxicity, but for a month or so of voriconazole, I have not personally seen toxicity. Okay, and I frequently consult my wife whenever I get a doubt about his infections.
Ramesh is lucky; he has an ID specialist in the house.
You know, it's always good to get married to somebody who is an expert in some things. And you should not worry about small things in life when you're on the verge of losing your eyeball. I can always do a transplant. I can do 2 transplants. I can do 3 transplants.
CNS adverse effects.
Huh?
It's just not endothelial toxicity, it's the CNS.
No, yes, but I don't know that I have not experienced that, and I see quite a few of these, and it's true that we have to monitor the overall health of the patient.
I mean,
Start the treatment and follow the patients.
I think long back when we were fellows, or probably we were postgraduates, there was no voriconazole, there was no ketoconazole also at the time. We used to give IV amphotericin B, and that had a tremendous systemic side effects. And that was something which was like crazy. The patient said, forget about the eye, this drug is causing too many complications in my body, and he used to refuse treatment. That was what the fate it was, but we are lucky in a state where we have some good antifungals, oral antifungals also available for us. Okay, we move on to the next presentation.
That was an interesting case, throwing light on so many points. So now we have Dr. Aruna Kumari, who is the head of refractive surgery in Anand Eye Institute.
Good evening, everyone. I'll be presenting 2 refractive surgery cases. Coming to case 1. A 28-year-old patient with compound myopic astigmatism came to a clinic for fitment for the job. His refractive error was -7 with -0.5 at 20 degrees in right eye, improving to 6.9, and -7 in left eye, improving to 6.9. So these are his quad maps, and these are the indices. All are normal. This is the pupillometry, and this is the endothelial map. All are normal. All were normal. So coming to the higher order aberrations, in right eye, the higher order aberrations were in the upper limit of the normal range, and in the left eye, it is more than the normal range. So when we asked for the visual standard for fitment for his job, he said the uncorrected visual acuity should be 6.6 in right eye and in left eye separately. But his best corrected vision with his refraction was 6.9 in both the eyes. Is there a chance that this patient will get 6.6 unaided? So we went ahead. We have done a refraction over the contact lens where his best visual acuity improved to 6.6 in both the eye. So a corneal wavefront guided trans PRK was planned in this patient, and we went ahead with the surgery, and the surgery was uneventful. So let's see the results. His visual acuity on 5th day, 12th post-op day, 19th post-op day, and 20th post-op day. By 20th post-op day, his uncorrected was 6.6 partial. By 1 month, he is 6.6 unaided in both the eyes, and he was fit for the job, and he got a job also. So here the take-home message would be, if the best corrected visual acuity is less than 6.6, check the higher order aberrations. Even if the higher order aberrations are more than the normal, if the best corrected visual acuity with the refraction over the contact lens, if it doesn't improve to 6.6, the corneal wavefront guided laser visual correction may not help the patient. So in this patient, as with the contact lens over refraction, it improved to best corrected 6.6. So we went ahead and did the surgery, and he attained uncorrected 6.6 vision. Coming to the second case, a 22-year-old female patient with -3 in right eye and -2.5 and -0.75 at 170 degrees in left eye came for vision correction. She doesn't want to wear a glass for life. That is her goal. So we have planned it, and the optic zone was 6.5 millimeters and epithelial thickness was 50 microns we have planned. So these are the quad maps of the patient. All are normal. This is the indices. They were also normal. This is the higher order aberrations. This is the epithelial map. So, because she was improving to 6.6, we planned for aberration-free corneal wavefront, aberration-free trans PRK, and the surgery was uneventful. To our surprise, the uneventful surgery landed up in a refractive surprise. So this is what was the refraction. Even after 3 weeks, she didn't improve in her right eye. Left eye, it was unaided 6.6. Right eye, from her pre-op -3 diopter spherical, she was left with plus 0.75 and -1.5 at 180 degrees, and she was improving to 6.6. So we don't know what happened. It was a uneventful surgery. Everything went well. So we went back and we saw the treatment plan. We thought that there would have been some transcription errors, but whatever data was entered, it was correctly entered. So to our surprise, the humidity and temperature in the right eye, from the last fluence to the time of the surgery, the humidity was decreased by 10 degrees, and temperature, there was also a variation of temperature by 5 to 6 degrees. So we just introspected ourselves on that day what happened. So I went to the theater, we asked the technician sisters, and this is what happened. Our operation theater door was not closed, and somebody entered in between when we were performing the right eye surgery. And the AC switches, we usually change the direction of the vent of the AC, and that day we didn't switch off. We have 2 ACs, one on the left hand side of the patient and one towards the foot end of the patient. So let's see what would have happened in this patient. Let's see if a person is moving. It is coming, it is coming. ప్లే చేయలేదు. So if a patient is moving, even to the slightest movement, what is happening to the air, the movement of the air at the head end of the patient, and how it will be interfering with the laser beam. So this is how the air drift interferes with the laser beams when a person enters into the theater in between the surgery. That is why we always ask even the fellows and students not to come into the theater. And this happened to that patient. And the patient was a dental doctor, and she doesn't want to have glasses forever. And they had a family history of retinal detachment. They were very apprehensive. So I asked them that we will retreat the patient and asked them to wait for 3 months. So after 3 months, her vision in the right eye was +1 with a cylinder at 90 degrees 6.6. 2 days back she came, and after 9 months her vision is +0.5 at 90 degrees. She's improving to 6.6. So she said, "Madam, I don't want any surgery no more. I am happy with the surgery." So what would have happened? So in the right eye, because of the opening of the door, there was humidity and temperature changes, and this has led to the myopic side of the correction. And because the AC vent was not switched off, usually we switch off or we will place the AC vent upside. So that was not done when we were doing the right eye surgery. So that happened, and it led to the irregular ablation of the cornea, which led to this mixed astigmatism. So the right eye, 2 days back we did the epithelial mapping, and the epithelium is still healing. So the take home message would be, we are operating, when we do a refractive surgery, we are operating on the virgin eyes of young patients. Pre-op workup is very important. Temperature, humidity, and whatever is causing any difference inside the theater, we must be very cautious. Be careful in entering the data, as the surgeon must be doubly sure that the data is entered clearly, and never be in a hurry to retreat the refractive surprises. And a double check is always important. Thank you.
So do you have guidelines for the humidity and the temperature of the room?
Sir?
Guidelines for guidelines?
Yeah, it is around, it is.
Can you share that with me if you don't
Yes.
mind, later by email?
Yes.
I just want to know.
Yes.
Thank you.
So this shows how much precision is needed in refractive surgery, including the AC vents. So next we move on to the cornea consultant, Dr. M.L. Karthika. She's going to present on DSEC.
Good evening, everyone. Good evening, everyone. I'm Dr. Karthika. Today I'm going to discuss about ultra-thin DSEC, double dissection manual method. It's been a century from the successful penetrating keratoplasty transplantation, and the evolution of the keratoplasty is like from the full thickness penetrating keratoplasty to deep lamellar endothelial keratoplasty, then Descemet's stripping endothelial keratoplasty and Descemet's membrane endothelial keratoplasty. This is Professor Jarrett R.J. Mellis, who first described the sutureless posterior lamellar keratoplasty. Until like few decades back, it was the only penetrating keratoplasty, the choice of surgery for all the corneal pathologies. But for the endothelial pathologies, endothelial keratoplasty is the best procedure. So we can avoid the most catastrophic complication of the penetrating keratoplasty, that is expulsive hemorrhage, post-traumatic graft dehiscence. And because in the endothelial keratoplasty there is no sutures, so there is no alteration in the anterior corneal surface, no astigmatism, and no suture-related complications. What are its advantages over penetrating keratoplasty? It avoids the surface incisions and sutures, it has a smoother surface topography, faster wound healing, fast visual rehabilitation, and greater tectonic stability, reduced graft rejection rates. The traditional DSEC thickness is 150 to 180 microns thickness, whereas ultra thin DSEC it is less than 100 microns, and DMEC it is around 10 to 15 microns. Indications for any endothelial keratoplasty: the most common indication is pseudophakic or aphakic bullous keratopathy, followed by Fuchs endothelial dystrophy and failed full thickness grafts. And rare indications are iridocorneal endothelial syndrome, post-TRAB or tubes, congenital hereditary endothelial dystrophies, and endothelitis. So let us discuss about the manual donor dissection. Before going to the dissection, the donor tissue selection is important. We need to select a good tissue, which one is fresh, and the endothelial count should be good, more than 2,500, and prefer phakic tissues, and it should have a good cell morphology. The instruments required for the dissection are artificial anterior chamber. It is, though it is disposable one, it can be used several times, and gauged blades which range from 300 to 600 microns, and the lamellar dissectors, straight and the curved ones, and crescent. Donor tissue preparation, before preparing the scleral rim, check the scleral rim. It should be adequate to lock into the artificial anterior chamber. It should not be too small that the button will decenter suddenly with loss of suction. It should not be too large, it will leak. Trim all the conjunctival and Tenon's tissue up to the limbus, then mount it. Check for the leak after mounting. Place the tissue. Here the scleral rim is adequate. Then lock the tissue on the artificial anterior chamber. Then check for the tension. Now the tension is adequate. If it is too tense, we may land up in perforation easily, and if it is too soft, we may land up in thicker grafts. Let us have a look at the double dissection of the donor tissue. Here initially I marked the center 7 mm of the cornea. Then with a gauged blade of 400 microns, the incision is given. Then the dissection is carried out with the crescent half the way, followed by the lamellar dissectors. Straight and the curved ones are used to dissect from limbus to limbus. Here, once the dissection is done with the lamellar dissectors, we cut it open like a flap. Then the second dissection is carried out. The same way, the incision is given. Then the dissection is started with the crescent. A small tunnel is created. Then the dissection is again carried out with the lamellar dissectors. Once the limbus to limbus dissection is achieved, the cornea is opened halfway, and you better mark it so that we will know the side upside, the stromal and the endothelial side. Why ultra thin DSEC? In eyes with limited visibility and the vitrectomized eyes with deep anterior chamber, complex anterior segment with large iris defects, trabs or tubes inside the eye, unstable IOL complex, and in these cases DMEC is not amenable, and younger donor tissues where the unscrolling of the tissue is very difficult in case of DMEC. Such cases ultra-thin DSEC is the best option. Automated DSEC, it has the highest cost because of the microkeratomes we use, but we get a very good interface and it is easy to do. Whereas in DMEC, it has the lowest cost, best outcomes, but it is a little difficult when and the learning curve is little more when compared to the DSEC. Whereas ultra-thin DSEC, it has low cost, it is ultra-thin and easy to perform. So this is the pre-op anterior segment OCT showing epithelial and stromal edema. This is a post-op anterior segment OCT showing ultra-thin DSEC very well attached and compact stroma. The key points for the dissection of the ultra-thin DSEC are check the storage media before when you get the donor tissue. If it is the MK media or the cortisol, MK media, the tissue tends to be little thicker than the tissues in the cortisol, and thawing is important. Make sure that half an hour or 1 hour before the dissection keep the tissue out. And gauged blades initially start with 350 or 300 or 350 microns. Then you can always go with the double dissection and achieve ultra-thin DSEC. And once we attain the experience, we can go ahead with the 450 or 500 microns and then go ahead with the single dissection. It is a safe and feasible and it is low cost. So take right path in difficult situations. Thank you.
Saying low cost, so in what way is this low cost compared to like a regular DSEC button?
Because you mean automated, sir?
Yeah.
In automated, because microkeratomes are required which are costly. Here, even if we use all these instruments,
that's how you reduce the cost. Okay.
so these instruments can be used again.
Right. So the second question along the same lines, the irregularity that's created by manual dissection compared to the automatic dissection, can you comment on that?
Yes, definitely, but as we do the double dissection and all, initially we create the pocket with the crescent, so like we can achieve little smoother surface also, but not as if in the automated cases.
So did you compare your visual outcomes with your manual dissection with the?
We usually go with the manual dissection.
Okay, yeah. No, yeah, I'm kind of spoiled because Lions Eye Institute provides us preloaded. Nowadays it's coming preloaded. We don't even have to unscroll, re-scroll, all of those things. Just shoot it into the AC and you're done.
Yeah.
So people in the United States completely forgot all of these original techniques.
So that is why we wanted to present it, because it is very cost effective in a country like India.
No, it's
where we can
in any country, in fact.
for the patients.
At the rate the United States GDP is going in terms of the amount of money that they're spending on healthcare, 25% of GDP, that will become like India very soon if they don't cut the costs. And no country can afford that kind of high-tech, expensive medicine. So this is great. Thank you.
Thank you, sir.
Thank you, Karthika. So next we have Dr. Taranam, who is going to give us a clinical research update.
Make sure that you have a couple of these things. I want to see this and I want to see your technique. I mean, I'm going to learn a lot.
Yes, ma'am.
So every time I come, I want you to teach me.
I'll give a brief overview on scientific publications from our institute in the last 7 years. From 2017, when Dr. Ramesh Ayara inaugurated the clinical research wing at our institute, we have come a long way and published 127 articles in various PubMed indexed ophthalmology journals. Last year at All India Ophthalmic Conference, one of our papers was awarded as one of the best publications in IGO in the year 2021. Our optometrists have co-authored 8 publications, fellows 21 publications, and residents 10 publications. Two of our residents, Dr. Shravanti and Dr. Swati, they have published a part of their thesis work in as original article. We have been co-guide to some of the PhD students from IIIT Hyderabad and NIN. In collaboration with International Institute of Information Technology, we have published 6 original articles in various ophthalmology journals. We have been collaborators in iGate's study group, which was published in November 2021. In December 2021, Indian Journal of Ophthalmology launched IGO videos, and they have 87 videos till date. We published our first video in September 2022, and last was in the last month of IGO, in the month of June. So far we have 14 videos, 12 have been published and 2 are in press. This year started with a bang, and we were able to publish 5 articles in ophthalmology glaucoma, 2 in ophthalmology retina and 1 in ophthalmology journal. This year was even more special as I was able to cross a milestone of 100 publications in my career. And it also reached a Scopus citation H index of 12. The journey so far has not been very easy, but we continue to do our work and keep contributing to the scientific literature. A special thanks to Dr. Anand Rao, Dr. Ramesh Ayala, Dr. Satish Agraharam, and the whole team of Ananda Institute for their support and constant encouragement. Thank you.
Awesome work. You know, coming to an institution like this, others have my comments in the end, but congratulations. I think you've been the soul of research in Ananda Institute. Thank you.
Next, I invite our chairman, Dr. Ayala, to address the gathering.
So I'll do it in 2 parts. Can I have my video? So I'm going to have my talk in 2 parts. The first 10 minutes I'm going to dedicate to a slice. Don't play it yet. Don't play it. Yeah. A slice in the life of Ayala, as I call it. And I'm very passionate about this simply because as I travel the world, more and more young ophthalmologists, they just want to do their residency and they want to go into private practice and cut as many cataracts as possible and make money out of it. There's nothing wrong in that concept, okay? Don't get me wrong. But what I would like for everyone to remember is this: 50% of patients really have complex anatomy, complex problems that encompass the entire anterior segment. And if we're going to train the next generation of doctors to become cataract surgeons only, and they're all stop their education soon after their residency, which is happening in my center in USF. It's happening in Tulane, where I taught 300 plus residents in my career there. And all over the United States, this is a new trend. Why? Because I can put in a IOL, like high-end intraocular lenses like Panoptics, charge $3,000. You make more money that way, but the flip side of the coin is patients with glaucomas, cornea problems, or a mixture of glaucoma and cornea, complex cataract surgeries, complications that happen after cataract surgeries, no one wants to tackle them. They're throwing them out into these academic institutions. And my generation is going to come to an end very soon. I mean, I'm 61 years old. anybody who crosses the age of 60 back in the day, we are told we are on borrowed time. I mean, now the average lifespan has improved to probably 75 or 80, but we are all on borrowed time to some level. So if your generation does not take up the challenge of getting further training to take care of this complex anterior segment pathology, what's going to happen is right now cataract is the main problem. 20 years down the road, cataract will not become the problem, but people are going to go blind permanently from complex anterior segment pathologies that you guys are not willing to take on. So my goal here today is to show a slice of my life. And this is my practice. You'll see a wide variety of cases. Hopefully you'll finish it in 10 minutes. But I want you to concentrate on the complexities of cases that I face on a day-to-day basis and what I do with them. So how do I switch? Okay, here. So here is the case with the bilateral aniridia, Morgaginian cataract, in the right eye, blind, painful, intraocular pressure of 65, left eye, Morgaginian, light perception, hand motions, vision pressure 25. No one in the state of Florida wanted to touch this lady. She went to Bascom Palmer, UF, and every other surgeon. Finally, she came to see me, and here I am operating on her eye. And when I was trying to take the nucleus out of this Morgaginian cataract in the right eye, you can see the red reflex changed. She ended up with a massive suprachoroidal hemorrhage in the right eye, and I drained it right then and there. Now, Taranam, I want you to watch this video. If there is any doubt in anybody's mind that suprachoroidal hemorrhage is arterial in nature, here is the evidence there. You see the pulsatile nature of the bleeding coming out. Even in the presence of complications in the middle of surgery, you always learn something. There was always this doubt in my mind as to where this blood is coming from. Now here is the question. Would I take the patient is booked for bilateral surgery. Would I take on the next eye soon after this massive suprachoroidal hemorrhage in the right eye? I did, because the patient came from 100 miles and she's not going to come back again. So here I am tackling the left eye, Morgaginian cataract. I did the capsulorhexis, and the nucleus floated out, and you can see vitreous in the wound, and there's plenty of vitreous coming out. So what do? I inject viscoelastic into the anterior chamber, and then I fall back on my old technique that my good friend Milind taught me back in the day when I was a resident here in SD Hospital, intracapsular cataract extraction. So knowing all these techniques really helps you to solve some of these problems that you have. So here I am practicing my intracapsular cataract extraction techniques that Milind taught me many years ago. We used to go out into this, I forgot the name of this place, village, where we used to practice when we were postgraduates. So here I am, I cut open the risk. Back of my mind, I'm thinking, is this lady going to have a massive suprachoroidal hemorrhage in this only eye, right? But I'm not worried. Patient is very happy with the results. With the plus 13, she saw 24 aniridia. You cannot get any more results, right? Now here is another patient, Stephen Johnson's lady, light perception vision, dense cataract. No one wants to touch her, so they think of Ayala. Nobody wants to do any surgery, then they send these patients to me. There's a dense pannus on the cornea, so I try to escape off a little bit of the pannus so there's some visibility, and then use vision blue. Successfully did the cataract surgery through that hazy cornea. No problems there. I've done many of these cases. The challenge is the cornea. So at the end of the case, I wanted the cornea to heal, so I put an amniotic membrane graft. 1 month later, 24-hour vision, patient was super happy. 2 months later, she presented with a cornea melt. Had to do an emergency cornea transplant. As you can imagine, case did not end well. Patient is dissatisfied. Take home message, Stephen Johnson's, no matter what you do, you can never solve this problem. Avoid surgery if possible in those patients. Here is a 10-year-old firecracker injury into the eye, presented with hypotony, cataract, cyclodialysis cleft, and a zonular dehiscence. Luckily, the cleft and the zonular dehiscence happen to be in the same location. So what do? I go in and take the cataract out, use the Ahmed segment into that area of the zonular dehiscence and the cleft to secure it to the adjacent sclera, thereby closing both the cleft and the zonular dehiscence area, put a lens in. Now the patient also had a blown out pupil. So I did a pupilloplasty, 20/30 vision, 15 pressures. This is about 15 years ago. Every year this kid is now a chemical engineer. He comes to me to say hi to me. His mother posts about me on Facebook every year on that day. Here's malignant glaucoma. Taranam, this is for you and you. So malignant glaucoma in an anophthalmic eye. So post-cataract, the pressures are 40, malignant glaucoma. So the treatment, like you all know, is vitrectomy. How do I know where to do the vitrectomy from? Pars plana. Where is pars plana in a patient with axial length of 16 millimeters? That's a big challenge, right? So what do? I go back to what my techniques, the techniques that I know. Do a trap, through the trap, a generous PI, through the PI, I put my vitrector, so I don't care where the pars plana is. I do this core vitrectomy, I come out, successful result, patient happy, vision restored, glaucoma cured to some degree. Patient is still on drops, but who cares, right? And now this endophthalmitis. Oh, it wasn't endophthalmitis when the patient saw me. Let me pause here. I'll tell you the story about this patient. 12-year-old boy goes to his friend's house for a sleep out, comes back home, mom is a nurse, complains to the mom that I'm not feeling well, and the right eye is irritable or something. The mom thinks it's a viral thing, so she takes the patient to the local urgent care. In the United States, there are a lot of these urgent care facilities, and anytime they say, you think it's viral, they give you a shot of steroid. So the patient ended up having a shot of steroid. 3 days later, the boy comes back from school saying that the eye is so red and irritable that he cannot open the eye. Local ophthalmologist sees the patient. He agrees that it's a viral infection, puts the patient on every hour Pred Forte. A week later is when this patient ends up on my desk. From a mile, you can see that there's a corneal abscess, lux fungus, fusarium, and the pressure was like 65 or something, and the pain was so high, the patient said, take my eyeball out. He kept on begging. We tried topical, drops, antifungal medications, oral, nothing worked, and eventually I had to take the patient back take the patient to the operating room. And as I am opening up the cornea, you can see the lens got extruded. Once, before the surgery, vitreous B scan was negative. Once the lens came out, I know I lost this eye. Because why? When fusarium tastes vitreous and retina, you're done. And unfortunately, as I proceeded with the surgery, you will see the reason why this delayed diagnosis cost this eye for this patient. The fusarium invaded the anterior chamber, invaded the pupillary area, grew under the pupillary area, causing a pupillary block glaucoma. And you will see this as I peel this off, that material from the anterior chamber. You can see the pupillary block coming off, and there comes the vitreous. I lost the eye. I had to do evisceration on this eye, on this kid. Here is a 33-year-old, all these specials only in the United States, right? Comes with a knife stuck in the, kitchen knife stuck in the eye. And the story is that her boyfriend is playing darts, and this lady walks in, gets this stuck into the eye, and there I am trying to pull this the knife out of the orbital bone, ends up with a massive laceration in addition to that. When you do these lacerations that extend from the limbus all the way down to the optic nerve, close it from the anterior to the posterior and try and avoid the uveal tissue along the way. My retina lady did a vitrectomy, oil fill, count fingers patient, retained the eyeball, so a happy situation. This is a nephrologist, got traumatized in his post-PKPI, lost the lens, could not tolerate contact lens, so came to me to fixate the lens. So I opened up the same area where the rupture happened in the cornea graft and put in a 3-piece lens, scleral fixation, 20/30 vision, great. I've not seen the patient again. 6 months later, he comes back saying that I'm losing my vision on and off. Sure enough, there's vitreous hemorrhage, and retina was clean. I suspected that the vitreous hemorrhage is happening from the site of the scleral fixation to the ciliary body, right? So my retina guy said, I'm not touching this eye. So I go in with my ECP, endocyclophotocoagulation curve probe, and what I do is to apply diode laser to the ciliary body. There you go, to the ciliary body where I found the haptics going in, going out of the eye, and following that treatment on both sides, to both the haptics and the core vitrectomy, the patient did extremely well. I've not seen him in like 4 or 5 years now because he's from out of town, so I'm assuming that he's doing well. So sometimes you have to think outside the box. Don't give up on patients just because you could not fix it the first time round. Here is a 3-week-old sclerocornea patient, only eye, the other eye is an ophthalmic, And the grandmother comes to me and says, my granddaughter is in your hands. Take care of her, right? So I did a cornea transplant on this lady along with a pediatric Ahmed valve with the same setting. And this transplant, believe it or not, cornea people here know, pediatric transplants are very difficult to survive. This particular transplant stayed clear for 6 years. The child went to school, started reading, and then 6 years or more recently, she came back again with a failed transplant and the cataract that nobody in New Orleans would touch. And by this time, I moved to Tampa. So she came to Tampa recently, and there I am. I took the transplant out, the whole transplant, and look at how powdery the cataract is. It's completely reabsorbed. And so as I tried to do a capsulorhexis, vitreous came forward, so I did a vitrectomy, cleaned up the situation, and put a 3-piece lens in the sulcus, and then put a new transplant in. The child is doing well. So there are lots of these kind of eyes that need anterior segment specialists. Every institution, every city will need an anterior segment person who is trained to do everything. You know, oftentimes you don't have a retina person. In all these 25 years of my practice, every year I get 2 or 3 suprachoroidal hemorrhages in my practice. High risk practice, that's what you expect. You do so many glaucoma surgeries, you will see complications. Suprachoroidal hemorrhage, when I go back, in fact, I have 2 suprachoroidal hemorrhages waiting for me to drain. The only time you can drain the suprachoroidal hemorrhage is on the table. When you see it happening, please take the time to actually make a sclerotomy cut right then and there. You decrease the blood load, and more than likely the patient's pain will be much better tolerated, and oftentimes you will resolve without any further drainage of blood. But if you wait for more than an hour, the blood clots, you got to wait it out for a 10-day period. So I have 2 patients waiting for me. That's my practice, my life. And my point here is, I sincerely hope that the postgraduates, and like I was pointing out in the last 2 days, the cornea surgeons and the glaucoma surgeons in this institution, train yourself to be a complete anterior segment surgeon. I was in LV Prasad today, and I ran into, is it Praveen, their cornea person? I ran into him when I was talking to Prashant. He said, you know, I want to work with you to create anterior segment fellowship. And the reason why is exactly what I told you. 50% of the transplants that they're doing, they're all blind. Post-transplant, they don't have any vision, useful vision. Why? Because somebody forgot to treat glaucoma. The number one reason why all these transplants fail is not because of transplant graft rejection, it's because the optic nerve is dead. Once the optic nerve is gone, at this point in time, we cannot solve their problem, right? So pay attention to glaucoma. It's a blinding disease, a permanent blinding disease. Right now, it's the world's leading cause for permanent blindness, by the way. So with that, coming to this eye institute, which is dear to me, it's been a 10-year walk with Satish Agraharam here, and a lot of memories going back to when I first met him, as to how we talked about this institution, how many times I had to travel to India to find him. I mean, it's hard, you know, you have a concept somewhere in your head, and then you think you're going to achieve this, X, Y, and Z, but you have to put in your share of work. Eventually, the goal, you will achieve the goal. And that came in the shape of Satish, because my good friend Milind introduced him to me, and then eventually it worked out. And the guiding, so the inspiration behind setting up Anand Eye Institute is the concept behind LVP, concept behind Arvind and Shankar Nethralaya. So patient care, teaching, and community care, service. So with those guiding principles is what we talked about at the beginning. So over the last 10 years, we had opportunities where we were thinking, is this possible to do another Arvind in 2020? Arvind was established 1970 or whenever, right? That model worked great. Can we recreate Arvind magic in year 2020 is the conversation that I was having with Satish yesterday. It's become fashionable now for private equity to come in, take away a lot of these big centers. right? I mean, once this is happening in the United States too. Once private equity steps in, you lose control. You become a number, as will the patient. So patient care goes to the side. And what comes to the top is money. So you have to produce X number of procedures, you have to do X number of OCTs, you have to do X number of FAs, everything revolves around money. Money is important, yes, but at the other end of the spectrum is, are we compromising patient care? That's an important question that we all need to ask ourselves. So at the heart and soul of this institution is Dr. Satish Agraharam. I can't thank you enough. Give him a round of applause. His hard work and dedication is the reason why this institution has come this far. Absolutely no questions about it. A man with a few words, but I've come to know him very well like a brother over the last 10 years now. And so thank you, Satish, for what you have done to this institution and to this community here, and all the postgraduates. Thank you. Sorry, I have a bad cold and I'm not able to shake off my post-viral drip. So, and then the faculty. You guys are fabulous. I learned over the last 3 days. You taught me lots of things, and today I learned quite a bit of how to take care of difficult patients. So I'm going to take this home and practice this kind of medicine to some degree in our own institution. So thank you. You guys formed the foundation based on which patient care is happening, outstanding. 2, teaching responsibilities. And 3, hopefully a post-pandemic work all over again. And so thank you for what you have done and what you will continue to do. This institution, I was talking to some of you yesterday, the core belief that we started this on will not alter. You know, one of the things in Coimbatore, I had the opportunity to sit down with the founders of Aravind, and I asked him this question: what advice do you give us? So he said, down the road, you will face many challenges and many for the situations where people want to come and buy you out. He said, don't ever lose sight of the core values that dictated as to why you started the institution. As long as you stick to those core principles, I think in the long term it will all work out. So in the next 10 years, what's going to be in store, we'll see. I think it's going to be good. I think it's going to be better than the first 10 years. The first 10 years is obviously the foundation. I think we have a rock solid foundation to build upon. And for the staff, you know, Mr. Vijay is not here, Venkatesh and everybody else. Really thank your staff from the front desk to the OR nurses and everybody in between. The 100+ staff members really form the core, and without the staff's help, no institution can run. So always be thankful to the staff, and the first thing you say to them when you see them is thank you. Really, and once in a while recognizing the staff for their hard work is a good thing for us to do. And I think tomorrow you guys are going to go take them out for dinner, and that's a good thing to do. And our board of directors, none of them are here today. Mr. Santosh Varalwar, the CEO of Vivamed, Dr. Anand Rao, and the original board member, Dr. Martin Ahmed of the Ahmed Valve fame and New World Medical CEO, no longer now. But I met him 2 weeks ago in Los Angeles, 3 weeks ago. And he conveyed his best wishes to Ananda Institute. He's still interested in knowing the progress of our center. So just so you know, he keeps sending me messages as to how the center is doing through his son-in-law, Bilal, who is now the current CEO of New World Medical. And so he wanted to convey his congratulations to Ananda Institute and all the staff and the faculty members here. And Santosh could not make it here today because he's away in Delhi or some other place. He played a vital role, and he continues to play a vital role in guiding the business end of our organization. So thank you, Santosh, even though you're not here. And finally, the reason why we're here today. You, the postgraduates, today's presentation is great. Really, the research concepts that you guys presented, it needs to be completed. You know, research is a long-term goal. Sometimes you're lucky, you will find the solution for it on day one. Those are the lucky few. Often, research means that you got to be persistent and persevere with the idea. Eventually, you'll find your goal. It may be one day, it may be 10 years down the road, right? But the concepts that you guys presented, that you are working on, hopefully we'll have the same conference next year. Every year, we're going to do the same thing. Every year, I'm expecting from next year onwards actual results, not just the concept and the background check. It's great. You started the projects now. Next year, let's complete the projects. And every year, this should become part and parcel of DNA of Anand postgraduate training. So thank you very much for all your hard work and enthusiasm. I can't, you know, I've been in training residents for almost 25 years now. When I was at Tulane, I trained more than 300 residents and more than 30 glaucoma fellows in my career. You guys are no less compared to anyone that I've trained in my past life. So congratulations. And to the graduate, you're the only graduate this year. Oh, right? You know, you'll be graduating soon. So to the graduate, congratulations on completing your DNB program in Anand Institute. So, you know, when you go into practice, it's the world is not a straight road. You will face many challenges in your both personal and professional career. And there will be lots of temptations that come along the way. As long as you follow the simple dictum that I followed in my life, is when a patient is sitting in front of me, before I sign up the patient for surgery, I ask myself this simple question. If this were to be my mom, my mother, would I do the surgery? The answer is yes, I go for it. If the answer is no, I don't go there. Simple thing in life, you can sleep nicely when you go home, because you know, doing cataract surgeries on patients who have 6/9 vision by telling lies to them, these kind of things are sometimes, like he pointed out, that patient with the fungal endophthalmitis, he had great vision to begin with. There was no business for anybody to actually touch the eye. Now the patient, luckily they found Satish, but otherwise he would have gone blind in the eye, right? So complications do happen. They're part and parcel of complications. If any surgeon in any conference stands up and says, I don't have complications, there are only two ways to accept that. A, they're lying, which is what they're doing, or they're retired and they're no longer operating. That's why they don't have any complications, right? So complications do happen. Take that into consideration when you decide on who you're operating. Train yourself to become extremely competent, not only in the straightforward surgery, but any complications. You choose to be a cataract surgeon, that's great. But know that there are complications following cataract surgery. At least first time round, you ought to be able to treat those complications yourself rather than relying on other people. That's how good you should be by the time you graduate out of the program. Alrighty, thank you so much and congratulations again.
On behalf of Anand Institute, I would like to take this opportunity. I would like to take this opportunity to thank Dr. Ramesh Ayala for organizing the international speakers and supporting us and making this a global event. Thank you, sir. I thank all the international speakers. I thank one and all who has accepted our invitation, who has come and joined us and made this event a success. Thank you, everyone. All of you, please join for the dinner.